Well, good morning, everybody. I would like to welcome everyone here at the studio and in our company attending this exciting one-day experience to celebrate the HTLV World Day, a date instituted by the International Retrovirology Association to call the attention to a virus, but mostly to show the world that there are persons living with HTLV who need the best of our efforts towards their well-being. The second edition of this webinar is primarily dedicated to open doors and windows to learn what the world is doing towards the public health policies, which will, at the end point, eliminate HTLV as an infectious disease of men. To start, I would like to invite uh, Juan David Sanchez, who will explain a little bit about the Zoom. Is David? Is David on?
So just to say that the attendees are just being let in now by the looks of it.
Well, this event is organized by the HTLV channel and PAHO OPAS, Pan American Health Organization and the World Health Organization. We would like to acknowledge our supporters, such as the Ministry of Health in Brazil, the International Retrovirology Association, the HLV European Research Network, the National Center for Human Retrovirology, the Brazilian Society for Virology, the Brazilian Society for Tropical Medicine, and the Brazilian Society for Infectology. And the organizing committee, which is composed by Carolina Rosadas from the Imperial College London, Tatiane Asson from the HTLV channel and the Ministry of Health, Leandro Soares Sereno from PAHO WHO, Marcelo Araújo de Freitas from PAHO, and Ruben Mayorga Sacastum from PAHO as well, and to Angélica Miranda from the Ministry of Health, and Graham Taylor from the Imperial College London. Just one notification is that there are poster sessions available, and the best poster will be awarded and with books. If possible, please leave your question in the video comment and authors will reply to you. The webinar is being recorded and will be available later. Questions are much welcome and attendees should send it in the question and answers. I would like to introduce for this opening ceremony, initially, Dr. Angélica Espinosa Miranda, which is from the Department of Chronic Diseases and Sexually Transmitted Infections from the Brazilian Ministry of Health. Angélica.
Oi, bom dia. Bom dia, Ricardo, bom dia a todos. É um grande prazer estar aqui com vocês. Eu inicio parabenizando a organização desse evento, porque isso vai dar muita visibilidade para todas as ações que a gente quer fazer em relação ao controle do HTLV. No dia 10 de novembro, a gente sabe que é esse dia que se comemora o controle do HTLV, e aqui no Brasil a gente tem sido muito estimulado, provocado pela organização desse simpósio, pelas pessoas que organizam esse simpósio, e aí por isso muitas ações têm acontecido. E aí a gente deseja um excelente evento a todos. Infelizmente o Dr. Gerson não conseguiu chegar a tempo, mas a gente dá as boas-vindas em nome do diretor do departamento, em nome do Ministério da Saúde do Brasil, e a gente fala da nossa grande alegria de estar participando com vocês, isso desse importante evento. Muito obrigado, Ricardo.
We thank you very much, Dr. Angelica. And I will call Dr. Ruben Mayorga Sacastum for his initial words. Dr. Ruben is the unit chief of HIV, hepatitis, tuberculosis, and sexually transmitted infections at PAHO Regional Headquarters in Washington, United States of America. Please.
Thank you very much, Professor Ishak, and a good welcome to everybody. Dr. Miranda, it's a pleasure to see you here. Our greetings from the director of PAHO to Dr. Gerson and to all the other participants. It is a very exciting time to be talking about HTLV and what we have been doing in terms of research, in terms of public policy, in terms of prevention. So I hope that we will have an excellent day discussing about all this. And I would like to welcome everybody and on behalf of PAHO. Thank you very much.
We thank you for your presence. We will start our program with the conference on the overview in the world and specifically in the Americas, a global public health agenda on HTLV. And Dr. Ruben Mayorga Sacastumi will prepare this conference for us. Dr. Ruben Mayorga is a medical doctor. He's a specialist in internal medicine and infectious diseases. He organized civil society in the response to HIV and the promotion of rights of people living in HIV in Latin America. He has held a UNAIDS senior office in several countries of the region like Peru, Ecuador, Bolivia, Argentina, Chile, Paraguay, and Uruguay, and in Geneva as well. Recently has been appointed as the unit chief of HIV, hepatitis, tuberculosis, and sexually transmitted infections in PAHO. We welcome Dr. Ruben for his conference. Thank you very much.
Okay, good morning, and I hope everybody can see the screen. Am I being, do you see the screen, Dr. Ishak?
Yes, we can do.
Perfect. So I will start with an overview. As we all know, the number of estimated people living with HTLV1 ranges from 5 to 10 million globally. And these estimates are based on data from countries, but we are lacking data from several highly populated countries. So this figure could vary greatly. And we have different studies that highlight that we have a very varying prevalence of HTLV1. In blood donors, for example, it is from 1 in 1 million to 1.3%. In pregnant women, it can be from 0.71% to 5.7%. And in the general population in the Americas, from 0.26 to 6.7%. We have seen that we have described transmission through blood or blood products. The first studies were presented in 1984, and it's been highlighted that transmission occurs mainly through blood products that contain cellular components, ranging anyway from 28 to 63% rate of transmission. Another route of transmission that has been described as very frequent route of transmission is organ and tissue donation, and transmission rates as high as 87% have been described in Japan among HTLV1 negative individuals previously. Regarding mother-to-child transmission, it is estimated that the transmission rate is around 20% without interventions, and mainly through breastfeeding. Transmission rate in the first 6 months of breastfeeding is quite low, and it is only with breastfeeding for more than 6 months that transmission rate increases significantly. There are several factors that intervene with transmission through breastfeeding, and one of them can be maternal HTLV1 proviral load in blood, in milk, associated myelopathy and tropical spastic paraparesis, a strongyloides infection, and some other factors that you all remember. We can see in this slide that transmission with no breastfeeding or short-term breastfeeding is relatively low, whereas it can go up significantly with breastfeeding that lasts for more than 6 months. Regarding sexual transmission, we find higher HTLV1 prevalence among populations that are at high risk of STIs, such as sex workers, men who have sex with men, and sexual partners of people living with HTLV1. Some risk factors that play a role in this transmission are history of unprotected sex, earlier age at first sex, a high number of partners, history of other STIs, especially ulcerous diseases, and a higher HTLV1 proviral load, as we mentioned earlier, in mother-to-child transmission. And of course, here too, we find a higher frequency of transmission from male to female. There are some HTLV1 associated diseases, such as adult T-cell leukemia and lymphoma, tropical spastic paraparesis or HTLV1 associated myelopathy, HTLV1 uveitis, and infected dermatitis, as well as many others that have been described, but the significance of relationship is less well established for the moment. Global and regional developments in the agenda against the HTLV1 have been very growing fast. For example, we have PAHO instituting standards of procedures of blood banks, encouraging screening of HTLV1 and 2 as early as 1998, evaluation of commercial HTLV1 kits by WHO, monographs regarding associations with cancer, monographs associated to transfusion safety and HTLV1 and 2 screening. The International Association for Cancer Research has also produced information about the risks related with HTLV1 infection and cancer. And we have had a big number of recent publications following consultations such as the one in 2019, a meeting of the PAHO STAG on disease elimination recommending HTLV1 as a candidate for elimination in 2020, and this webinar that we are all engaging in right now. One of the very important recent publications is this meeting report from 2019 that issued 12 recommendations regarding surveillance, regarding testing criteria, transmission associated with breastfeeding, integration of HTLV1 prevention interventions, and others that you can see here. And this is an excellent background document. We also have this HTLV1 technical report from 2021, speaking about the epidemiology of the virus and the figure of 5 to 10 million people infected globally, the conditions that are associated to HTLV1 infection, transmission, testing, care, and treatment, and prevention interventions that you will see here, such as cessation of breastfeeding, breast milk freeze and thaw methods, antibody screening among blood donors, and leukoreduction, mainly in higher income countries, as you will see later on. And priorities of what needs to be done in the future, such as surveillance, guidance on testing, integration into sexually transmitted infection management and PMTCT, and much more research. Oops, sorry. Some gaps about the knowledge that we have include the better understanding of the epidemiological situation that doesn't allow us to have comprehensive national policies in most countries, since we don't have information from many countries. The data we have from 69 countries indicate that 14 of these don't have any specific policy for HTLV1. 55 had at least one policy for preventive interventions, and the rest didn't have any information. Overall, there are some policies for the prevention of HTLV1 transmission, such as screening of blood and tissues, and the interventions I mentioned regarding breastfeeding. Some other countries have policies related to sexual transmission and bloodborne infections, and a few other public health methods have been implemented to manage ATL or HAM STP. For example, regarding blood donation, we see that many countries have a number of interventions. The one that has the most is the European region, and you can see that mainly high-income countries are the ones that have measures regarding local reduction for avoiding the transmission of HTLV1. In the Americas, we have policies regarding donations in most of the countries, and also in specific areas in Argentina and the Bolivarian Republic of Venezuela. We can see here that the average screening coverage of blood units in Latin America is relatively high, around 90%. And you can see at the right-hand side, the countries that are doing it and the ones who are not yet doing it. So regarding the policy uptake, interventions that have been reported in several countries are antenatal screening. In Japan, it is universal. And in these other countries, it's related to risk factors in France, Brazil, and Chile, for example, followed by cessation of breastfeeding, shortening the duration, as I mentioned, and especially having it last less than 6 months, and testing infants born to HTLV1 positive mothers with no standard algorithms in Brazil, Chile, and Japan. Screening of breast milk donations, such as in France and in the United Kingdom, if there are risk factors reported, and this other method that we mentioned already. Regarding diagnosis and care, there are no international standards regarding HTLV1 diagnosis, but multiple assays are required in most places. We have a lack of epidemiological data to decide on the best algorithm, and we don't have any WHO pre-qualified tests. And there has been reported a cross-reactivity, for example, with Plasmodium falciparum infections. And there is regard to cost, that it can be quite high in low prevalence settings. In some countries, some other people are being tested, such as in Australia, healthcare workers that are exposed, and in people who have some risk of transmission regarding sexual relations or injecting drug use in Chile and Brazil. And treatment guidelines, there is very limited experience from clinical trials, but there are some guidelines for managing ATL in Brazil, Japan, US, UK, Chile, that are based basically on expert consensus for good practice. What are some of the challenges and next steps regarding HTLV1? We know that it causes a range of severe diseases. Those are the ones that I have already described, but there might be some others. We would like to know if there is high burden in some communities and geographic locations. There are many places where serological studies have not been carried out, so this is knowledge that we don't have yet. We have major gaps in knowledge and data in these very populous countries where we don't have any data from, in North and East Africa and Southeast Asia. HTLV1 surveillance is not systemic. Regarding prevention of mother-to-child transmission and sexual and blood transmission, we don't have international public health and policy guidelines yet. We have to take advantage, of course, of this renewed interest in HTLV1, increasing public awareness, such as with civil society activism, media reports, and other social media. I hope that this meeting is playing its role. There are some emerging evidences about things that can be done, but dissemination of findings are still limited. And of course, requests from WHO member states can take WHO to take action. WHO would be expected to provide guidance on surveillance, prevention, screening, and care, promote a comprehensive public health response to this infection, integration into other healthcare methodologies, and first level of care, and support research to close knowledge gaps. In the Americas, we have an elimination initiative that would have elimination of several infectious diseases in 2030 as a public health problem. It builds on several achievements in this region. It links over 30 global and regional strategies and plans of actions into one structured and unifying framework. And it provides a framework for the attainment of 2030 SDGs and the Health Agenda for the Americas 2018 to 2030. This platform can be an opportunity to promote an HTLV1 elimination agenda regarding feasibility, targeting, goals, and strategic lines of action. I thank you very much for your attention, and I hope that this initial presentation will lead to a wider discussion today. Thank you very much.
We thank you very much for the conference, Dr. Rubin, and I'm sure that people have enjoyed a lot knowing the present situation of HTLV. I would like to invite now Professor Graham Taylor in order that he can head the session number 1 in health policies around the world. Professor Graham. Carolina. Yes, you can talk, Professor. Dr. Rubin, do you want to talk something else?
I'm sorry, I think I raised my hand by mistake.
Okay. Please feel free if you want to talk something else, because I think Professor Graham is still having some problem.
Eu acho que o professor Graham está tendo problema com conexão. Eu vou, então, apresentar a doutora Fabiola. Doutora Fabiola Martin, ela é sexual and reproductive health physician, scientist, medical educator, and patient advocate with expertise in HLV and HIV medicine. Fabiola completed her medical training in HLV1 associated myelopathy at Imperial College London in UK. And in 2018, Fabiola put her idea of persuading the World Health Organization to adopt HLV as a health topic into action by leading the International Working Group on HLV WHO open letter that was published in Lancet. She's the president of International Retrovirology Association and the Sexual Health Association Queensland. She is also the co-founder of patient website www.hlvaware.com and the podcast editor of British Medical Journal Sexually Transmitted Disease. Thank you, Dr. Fabiola, for joining us.
Thank you very much. Can everybody hear me?
Yeah.
Thank you so much. So I just want to start.
Dr. Fabiola, I think your slides are not in full presentation mode.
How now?
We can see the next slide as well.
One moment.
I think it's display
now?
set.
How about now?
No.
What do you see now?
I can see the next slide as well. The current slide is not in full screen.
I don't end slideshow. Stop share. I try. I try again. I don't know what's going on. Before we had no problem, but now we seem to have a problem. So I try again. What can you see? What can you see?
Perfect.
Yes?
Yeah, perfect. Thank you.
I'm glad to see that. Okay, let's start. Right. Hello, and thank you for the invitation. I would like to start my presentation with acknowledgement of the country. I acknowledge the traditional owners and custodians of the land from which I speak to you and pay my respect to Turrbal and Jagera people in Brisbane. Sovereignty has never been ceded. It always was and always be Aboriginal land. So I am Fabiola Martin. Thank you very much for asking me to speak to you today. This is my first public lecture in my new role as elected president of International Retrovirology Association, and it's an honor to be here. I wish to use this opportunity to thank the conference organizers for the gender justice of the speaker distribution today. Well done. I want to proceed to the presentation. So, I was provided with this title for my talk. It is time to eliminate HTLV 1 and 2 and the why. So when I read this, I must say I was a bit frustrated and I went for a long walk. And so I was thinking, the why, really? Have we still not moved beyond this question? The reason why I think this way is because, as far as I know, nobody wants to have an STI. You know, HTLV is an incurable oncovirus. It's integrates itself cleverly into your DNA and spreads through your body. Nobody wants an STI. Nobody wants an incurable STI, and nobody wants to pass it on to their loved ones and see it being passed on to their baby. So that's maybe reason number one. And you may know the recent data published by Masako Iwanaga in 2020, where he presents us with the latest data that they have on the epidemiology of HTLV in Japan. So in 2016, in Japan, despite excellent antenatal testing and patient support, the nationwide annual incidence of new infection with HTLV is estimated to be 3.8 per 100,000 persons years. And the incidence rate was 3 times higher in women than men. And each year, 4,000 new HTLV infections occur in Japan, mostly in adolescents and adults. And so it is sexually transmitted and the burden is carried by women. And guess what? This is not news. We have known this for at least 2 decades. So yes, sex is a major mode of transmission for this STI. Of course, it's also a blood-borne virus, but in many countries, we are trying now to control that through effective screening of our blood donations and organ transplantations. And so, yes, HTLV is an STI and predominantly transmitted through condomless intervaginal sex. And if it is also transmitted from parents to their babies, because, you know, mothers need to have been infected somehow, and which is often through condomless sex. And please do recall that the most common mode of getting pregnant and making a baby is also condomless sex. So this is all connected. And yet we come back to what I see in my clinics. Nobody wants to have an incurable virus, of which HTLV is one. So if that doesn't persuade you to eliminate HTLV, let us look at what else it does to people. So who wants to die of cancer? I guess none of you. I don't want to, for sure. And this lovely patient of mine, and Graham Taylor, died of his HTLV caused adult T-cell leukemia. As you know, lymphoma, actually, in his case, there are 4 different forms and 2 aggressive forms. He suffered from lymphoma. So a lovely lecturer who was seeing us initially for HTLV uveitis, then for HTLV myelopathy. And because we could not cure him of his HTLV, he sadly developed lymphomatous ATLL. All his lymph nodes were packed with HTLV cancer cells. They were swollen, they were painful. And no matter how hard we tried, he still died of ATL at the end. And that was at one of the best HTLV care facilities in the world, at the National Center for Human Retrovirology. And he survived only 6 months. And let me tell you, these weren't comfortable months for him. He was given all sorts of chemotherapy. He was enrolled in a clinical trial, and he was mostly hospitalized. It was a very uncomfortable, low quality 6 months of life for him. And it certainly traumatized me, and I'm sure Graham was also suffering. So it's another really good reason. So who wants to die of cancer? This question, you know, you can repeat that to yourself whenever you need motivation, because over the last decades, the mortality, the survival of people who suffer from ATL hasn't really improved. And you see these Kaplan-Meier graphs, which some of you may be bored by, because we see this again and again, and not much has changed. The median survival of aggressive types, despite chemotherapy, is only 8 to 10 months. And by the way, as discussed, this is quite miserable 10 months for those who are suffering of this. And I think by now you get the picture of what patients and their health carers have to face, because we can't cure patients of this virus, and we can't cure almost all of our patients unless we take very drastic measures of the ATL. And we have this again confirmed by recent data by Masako Iwanaga, in that between 1999 and 2017, the number of deaths due to ATL, which is 1,000 patients each year, I repeat, number of deaths due to ATL in Japan is 1,000 patients per year, has not changed over the last 18 years. So moving on, let me ask you, who wants to be forever wheelchair bound with HAM-TSB? My own research at the National Center for Human Retrovirology, Imperial College London, was on the natural history of HAM-TSB. Patients are wheelchair bound by about 20 years after diagnosis. Now, this is again not just some lovely woman sitting in a chair comfortably. No, it starts with being unable to hold your urine, unable to catch a bus, unable to take your child to school, unable to go to work, unable to continue education or participate in the social life of your family and friends, which leads to utter isolation, associated and combined with lower backache, spasticity and stiffness of the legs, hyperreflexia, which is quite unpleasant, bladder and bowel dysfunction, and sexual dysfunction. It is a miserable life. So who wants to go blind? HTLV1 uveitis, alveolitis, shortness of breath. I'm sure Lloyd has a lot to tell us about that. Disfiguring skin rashes such as infective dermatitis, as well as severe scabies, life-threatening worm infections with Strengyloides stercoralis, which is hyperinfection associated with underlying HTLV infection. And you see a histopathology slide of a lung infested with larvae, chronic muscle pain and ache and joint. I don't think anyone would like to catch an STI that could cause these. And in the middle, you see a figure that we published together with Graham Taylor and Steve Jacobson, listing all those many different inflammatory conditions associated and caused by HTLV1. And as mentioned before, all this leads to decreased socioeconomic status, education, job opportunities, poverty, mental health disorders and other morbidities, and increased mortality, premature death. And finally, if you don't mind suffering from all these problems caused by HTLV yourself, none of us want to see their child suffer from infective dermatitis. And a lot of you guys, especially in Southern America, you have patients who have carried the virus themselves and they have children who are suffering. This is a painful, itchy, disfiguring, stigmatizing condition of Staph aureus superinfection in people, in children who have the HTLV1 infection. So is it time to eliminate HTLV1 and 2? Yes. Why? Because nobody likes to have an STI, go blind, be wheelchair bound, have chronic pain, have sexual dysfunction, lose their job, and be poor, be stigmatized, ostracized, die of horrible cancer, or see her child suffer. I could stop here, couldn't I? But please indulge me, let me talk a bit longer. And so what the real question is for me is, why is this virus still around and without effective surveillance, control and cure? Recall, this virus was identified by Bob Gallo's team in 1980. I presented this slide for the first time in Melbourne in 2017. I wanted to visualize all the interventions we have to help people suffering from hepatitis B, HIV, hepatitis C, and identified that there is really quite a lot available in my toolbox to offer to all my patients who carry these viruses, but hardly anything for my HTLV patients. And most importantly, the interventions that I have for all the other 3 viruses are very effective. A vaccine for hepatitis B, as well as treatment, suppressive effective treatment for HIV, and a cure, 1 tablet a day for 3 months in Hep C. Then there are public health interventions implemented all over the world. And then look at the column of HTLV. This is just shocking. We have a test, it tells us that someone's positive, and often they just get a letter through the letterbox because they wanted to donate blood. They're told they cannot donate anymore because they have this virus. And most of the time, the patients don't know where to go. As Rubin just beautifully illustrated, there are some countries who do really well in testing blood and organ donations, offering antenatal testing and support, and preventing mother-to-child transmission. Martinique, part of France, is one of the best examples, and of course Japan, the next best in my opinion. So I must say, this is how I came to want to write the letter to WHO. And I went to Bob and said, and asked him to join me in writing this letter. And Bob and I led a writing group together with Tyler Yutaka Tagaya, joined by 70 other co-authors and patient reps and lived experience patients and send a letter to WHO. We are trying to raise awareness. We are trying to make people see this virus and try to eliminate it. So together with GVN, Global Virus Network, and International Retrovirology Association. Then remember, we have now, thanks to Toshi Watanabe and Johan van Weidenberg, the World HTLV Day that we can use to get together and raise awareness. And then, of course, one of our wonderful activists, Dr. Lloyd Einsiedel, who will speak later on, has raised awareness of this virus internationally by making readers aware of the lack of support for First Nation people of Central Australia, burdened with high HTLV morbidity and premature mortality. So the next real question is, why is there no investment into HTLV cure and prevention? Could it be that the clinicians and virologists are busy with other pandemics? Recall 1980, when HIV hit our world, another zoonotic disease, another retrovirus, most probably transmitted through anthroponic interaction of humans with the natural world. And so we have the HIV pandemic, and now, of course, in 2020, the COVID pandemic. And you do know a lot of our colleagues, virologists, are experts that are called away to work with these bigger, more virulent viruses. And so we run out of brain power, and we also are burned out because a lot of us have been working ridiculous hours, especially over the last 2 years. And there may not be enough of us to go around. So we need resources, we need research funding for fellows. I personally, for example, had to apply many times, starting with Charles Bangham twice and then with Graham, to get funding to do my MD in 2004, starting in 2004. So it's not, HTLV research is not very welcome. I'm almost done.
Almost done, good.
Could it be that, hello, Graham, good to hear you. Well, could it be that women and girls remain disempowered? So as you know, HTLV is a disease burdening women most. Poverty, women and girls, discrimination against Indigenous people leads to lack of education of this cohort, little health education in this cohort, almost no sexual health education, and lots of STIs, babies and parent to child transmission. So like most STIs, this affects girls, women and their babies, perpetuating a vicious downward spiral. We need to empower our women and our First Nation people. Yes, it is time to eliminate HTLV, but whatever you do, include people burdened with HTLV into your research, design, trial and ethical committees, service development. Remember, patients own their results. If you take bloods from them, you need to go back and give them the results and connect them with services, connect patients with HTLV services, support partner notification, and invite people burdened with this virus to speak at our meetings. Nothing about us without us, invite your patients. So, and finally, a plug for the conference coming next year. Please come and join us, and a podcast on this World HTLV Day.
Thank you, Fabiola, for tackling that subject that we threw at you and doing it so well, and from all your personal experience. We're going to have our questions and answers all together at just after 10 o'clock UK time. So we'll please keep adding them to the Q&A. And just for those people who've been arriving during the last half an hour, welcome. And just be clear that there's interpretation into English, Portuguese and Spanish. If you go to the globe button, you can get the language of your choice. So we're missing at the moment our next speaker, Professor Yamano. So we're going to go straight now to Dr. Divya Dashmana from London to describe how things are done, for better or for worse, in the UK. Divya. I should say that Divya is the consultant physician and now the HTLV clinical lead at the National Centre for Human Retrovirology in the Department of Sexual Health, HIV and HTLV, which is in the Division of Medicine and Integrated Care at Imperial College Healthcare. And she completed her specialist training in GUM and HIV in the West Midlands, where she joined the HTLV clinics there. And she's also, I'm delighted to say, leading the authorship of the first British Association of Sexual Health and HIV guidelines on HTLV for our sexual health physicians, which is a first step, I believe, to bringing HTLV screening into the mainstream of sexual health in the UK. Divya, you have 15 minutes, and when you see me again, you'll only have 2 minutes left to talk. Thank you.
Thank you, Graham. It's a pleasure to be here. Thank you for asking me to speak. Can you see my slides?
Yes.
Okay, so I've been asked to describe the public policies for HTLV in England and to share our experience of the clinic here in London. Right, if I can set the scene, so the United Kingdom has approximately 67 million people in the country. We have calculated that in the UK, there are between 20,000 and 30,000 people living with HTLV. A study that was a collaboration between our clinic and Public Health England, which is the government body that manages the country's public health, found that over a 10-year period to 2013, there were nearly 900 people diagnosed with HTLV. 65% were women and similar from all Caribbean backgrounds. What's interesting is that 55% had symptoms of HTLV-associated disease at that time. Now, last year, I looked at our figures and our service saw between about 400 and 500 patients last year. And actually, most of them, 65% now, are asymptomatic carriers. So I think this is a reflection of wider testing of HTLV in the country. But clearly, you can see a gap between the 900 patients and the 20,000. So there's still a lot more work to be done. Most of you are familiar with this data from Jassan and colleagues, and as you can see, London is in a relatively lower prevalence area. However, we do provide a bespoke service to all of those with HTLV within England. We sit within the Department of Sexual Health and HIV within St Mary's Hospital, which is a teaching hospital, so it's linked to a medical school. We're part of Imperial College London, which is known internationally for its research, and we're in the capital city, London, only a stone's throw from Paddington train station, which is a major railway station in England, so very accessible. A very simplistic view of the National Health Service. So the National Health Service is the body, the government body that provides healthcare free at the point of access to most people in the country. Essentially, what you need to know is that some conditions, such as HTLV and some cancer services, are funded at a national level. And other services are funded at a local level. So in England, if you need to go and see a doctor, first you visit your general practitioner or your GP, and then you'll be referred by that doctor to a specialist in your own area. You can't access a specialist directly. This is different for HTLV, where you can access us directly. So with HTLV, you'll need to travel outside of your local area. And so separate money is allocated to cover the cost of this so that your local area doesn't bear that cost. So what policies exist in England for testing for HTLV? Now, these images show transmission as an aid to help me to talk you through this. So there are not as many policies as we would like, and perhaps the WHO stance will help with this. Now, if you look at the figure on the left, if you visit a clinic where they look for sexually transmitted infections, or a GU clinic as it's known here, you will not be routinely tested for HTLV infection. if you're pregnant and you go to antenatal clinic, you'll be tested for other bloodborne viruses like HIV or hepatitis. You won't routinely be tested for HTLV. Similarly, for organisations where people who inject drugs are seen. Now, if you do donate blood, since 2003, we routinely screen donors for this infection. And more recently, actually as a result of European directives, it is recommended that both donors and transplants of organs and tissues are screened for HTLV infection. Again, over the last 5-6 years, if you're receiving fertility treatment, and that involves the receipt of eggs or sperm which have been frozen, if you are a high-risk person, or your parents are, or your partner is, you will be tested for HTLV. Similarly, if you decide to store your baby's cord blood, certain high-risk populations will be screened for HTLV. The problem in that last issue is that the cord blood is taken at delivery. By the time mum gets her results, which could be 2 or 3 weeks down the line, she's already begun breastfeeding. So what have we done here to manage and deal with this? From a point of view of sexual health, as Graham has already mentioned, as Professor Taylor has already mentioned, we are working on guidelines so that testing for HTLV can be incorporated into daily practice at a GU clinic. Regarding antenatal clinics, the UK National Screening Committee sits on a regular basis, and they are due to sit at the moment. They have already sat and debated the option of screening all women for HTLV, and in 2012 and 2017 they declined. So we have written a letter to lobby them once more, and we've also made our patients aware of this so that they are also able to lobby from their behalf. Looking at transmission from medical, the Hospital St Mary's that I work in, we have updated the local guidelines recently and are disseminating them outwards so that everybody who sustains a needle stick injury through occupational exposure is tested for HTLV infection. We're also working with the UK advisory body on bloodborne viruses and occupational exposure. We're working with them to gather more data about how much of an issue this is. Just to, I thought I'd outline the principles of care of our service. So at the heart of the service are those people living with HTLV and their families. Now, care should be accessible to all in any part of this country. If you can't afford to travel to us, the costs of your travel are covered. If your GP hasn't heard of HTLV, you can come directly to us. If you have a physical disability, you can use our ramp, and our buildings and doors are wide enough for access to wheelchairs. Furthermore, as part of a patient and public participation, you should be able to tell us what sort of care is important to you and what research you think is important and what kind of research you would like to participate in. So supporting this core is the requirement for a diagnostics laboratory, again, in the vicinity of the clinic, and a research facility which can explore pathogenesis and treatment because of their ease to access to patients and samples. And in this environment, clinical trials can occur where novel therapies can be monitored. The outer circle is the interface with those outside the service. We are able to provide advice to other healthcare professionals and to the public, and this may be within the country or outside. We often receive emails from patients and doctors abroad looking to ask us about various information. And this has particularly been the case during COVID. Interaction needs to occur with government bodies to shape further service development. And there needs to be a conversation with those providing medical education. And that conversation has also begun here so that there is more expertise within the medical profession. So this is actually what it looks like. Again, I'm going to direct you to the people living with HTLV. So Professor Graham Taylor established this service in 1991, and it has grown steadily over the years. And he mentions that he started with 1 clinic a week. So patients living with HTLV over the course of this year have been involved in a series of conversations to find out what is important to them. I'm trying to show you my cursor, and how they would like to see change in their service. And that's been quite a popular part of our year. If you look on the left, there is the hub, which is at St Mary's Hospital. But if you look at the far right, we also have spoke clinics in other parts of the country, currently in Birmingham, Manchester, and York. And the idea is that this is easier for patients to access. And usually it's been Graham traveling up to these clinics, but more recently, other members of the team have been traveling up to provide the expertise and to train the clinicians in those areas. I've talked about, I will talk about a specialist team in the clinic who look after these patients, oversee their care. We collaborate with the government body. Currently, its name is the UK Health Security Agency. It used to be called Public Health England. But essentially, they capture data on epidemiology of HTLV within the country. They also host a voluntary and longitudinal register in which patients who have no symptoms are asked questions on a regular basis. And recently, we asked questions on COVID. We liaise with NHS Blood and Transplant, as that's where many of our referrals come from. And I've mentioned the lab, which is adjacent to our clinic. So we have 3 outpatients clinic a week, and we have consultants in haematology and neurology. And the structure of the clinic is really, we have doctors, we have a specialist clinical nurse, and we have a neurophysiotherapist. And we can access the appropriate investigations and refer to other specialties within this hospital and outside. And we can also have inpatients as required. This is our very happy laboratory MDU team, and they run the diagnostics for the patients in our service and those outside. And what we would like to see, obviously, is to be able to extend routine screening in all of these populations and groups. And the more this happens, the more we can tackle the stigma that exists amongst patients and the public in general regarding HTLV. We have a website, htlv.eu. Please do have a look at it, and you can contact us on that email, and that is our QR code for the website. Finally, to acknowledge the clinical team who are listed on your right. And there's also a picture of some of the clinical team who were in clinic 2 days ago. You can't see our smiles behind our masks in this current COVID environment. But we are smiling, despite it having been quite a tough few years with COVID, when the pressure from above was actually to close the service. But we did keep it going, and we're still here today. So thank you to the team for working, and thank you to all for listening, and I hope this has been useful.
Thank you, Divya, and thank you for being so clear and also sticking to time perfectly. And we will be taking questions. There are some coming into the Q&A. We'll look at those. There's some interesting questions in there as we get to the later part of the program. So I'm going to move on, I think, to ask Lloyd to go next. Lloyd is well, I always think of Lloyd as a specialist in infectious diseases, but he's a clinical researcher, specialist in internal medicine, and has studied in the Flinders in Adelaide and Monash in Melbourne. Did work on neurovirology of HIV in Melbourne, and moved to Central Australia in 2005, where he really has been blazing a trail of both care and research for people affected by HTLV in the Northern Territories. He's the executive director of the Baker Heart and Diabetes Institute, and has been publishing some really important findings which inform all of us but also particularly important in the region. And is working obviously very closely with the Aboriginal community. And I was privileged to visit there a couple of years ago and just get a slight taste of the challenges on many levels that Lloyd and the team out there are facing. Lloyd, over to you. You've got 15 minutes to go. I think a whistle-stop tour of our public health policies in Australia and epidemiological studies in the vulnerable population. Thank you. And I will reappear in 13 minutes.
Terrific. Thank you very much, Graham, for that introduction. And thank you also to the organising committee for asking me to talk about what really is a fairly complex situation here in Central Australia, and probably more difficult to talk about than the retrovirology itself. I'm actually back with the Northern Territory Government now, working in clinical medicine and doing clinical research along the way. Today, I just wanted to briefly mention the virus we have in Central Australia and discuss a little the implications clinically of the virus, talk about the epidemiology here, the community prevalence, the Australian response to this information, and then a bit on the barriers to presentation in our setting. So in Central Australia, we have HTLV1 subtype C, as I'm sure most people are aware. This is one of the Australo-Melanesian HTLV1 subtypes. We have different clades here in Central Australia, and this is something that Olivia Cassar and Antoine Gassain looked at some years ago.
Lloyd, are you?
Yes.
You're not sharing a screen yet.
Sharing?
Not sharing.
Sorry.
Have you got slides? Sorry, I should have.
I do have slides, and I thought I was sharing. Hold on. I'll try again.
Looks like it's coming. Yep.
Coming?
I've got slides. They look like they're yours. Brilliant.
Awesome. Okay. Sorry about that. I'll just, so what we're talking about, HTLV1 subtype C here. So this is a Australo-Melanesian subtype. In Central Australia, we see both adult T-cell leukemia, and we see a case every year or so, so relatively uncommon, but I've diagnosed most of these, so I suspect it's a question of underdiagnosis, but also inflammatory diseases, and as Fabiola has already mentioned, these can affect various organs, but we would mostly see HTLV1-associated pulmonary disease, occasional cases of myositis and uveitis and ham-TSB. So we looked at the overall prevalence of HTLV1-associated diseases and inflammatory diseases really in this community survey, and this was done blind to HTLV1 status, and found that around 16% of 218 individuals in this community survey had either bronchiectasis, ham, IDH, uveitis or myositis. And this is associated with a significantly higher proviral load, as you can see, for both women and men. Correcting for the background rates of bronchiectasis in an environment with poor social circumstances, that probably around 10% of people would have an HTLV1 associated disease at any given time. The community survey also found that high proviral loads increases risk of any HTLV1 associated inflammatory disease. So increasing with the low proviral load, increasing the adjusted odds ratio at 3.26 with a high proviral load to 8.7, and looking at radiological evidence of bronchiectasis to 14.4. This data is similar to that which was has previously been published in our hospital-based studies. So we showed that a high HTLV1 proviral load predicts bronchiectasis in this case control study with an adjusted odds ratio of 12.4, and also that there's increasing risk of pulmonary injury as the HTLV1 proviral load increases. We've also found an association with death, so death from bronchiectasis is higher among those with a high proviral load, and also a high HTLV1 proviral load independently predicted death in follow-up of the case control study. So around fourfold increased risk of death, even when you factor bronchiectasis into the model. Looking at the epidemiology, we have a large endemic area, and this extends over the Northern Territory, Western Australia and South Australia. I'm sitting here in Alice Springs, and the data from clinical studies, so this is seropositivity data from clinics where people are presented and have HTLV1 tests done, so not really community-based data. But nevertheless, there's this impressive gradient from relatively low levels to the north of Australia, right down to around 50% of all individuals tested being HTLV1 infected. Again, this is all seropositivity. Also high rates, though, in the far north of Western Australia, so 17.4% for adults and 15% for children. And this is from data taken from blood samples collected in 1977. We looked at risk factors for HTLV1 within the Alice Springs Hospital and found that increasing age, male gender in our setting, residents to the south and west, and also a sexually transmitted infection in the past was associated with HTLV1. We've gone on to do, in the community survey, we've done HTLV1 studies in the context of a prevalence study. And this is a fairly large study by our standards, encompassing some 70,000 square kilometres to the west of Alice Springs here. And we've found increasing prevalence rates reaching 50% in individuals over the age of 54, and again rates higher in men than women. But the overall adult community prevalence of 39% is the highest recorded to my knowledge. So just to summarise this, the current knowledge. So we've known that HTLV1 is present in Central Australia since 1988 with extremely high adult prevalence of 39%, likely predominant sexual transmission, although further studies by Aboriginal researchers are needed to clarify what the other risk factors, if there are other risk factors, what they might be. We also see adult T-cell leukemia and HAID, including HAM. Around 10% of HTLV1 infected people were symptomatic in the cross-sectional community survey. Corrected around 8.5% of individuals having bronchiolitis or bronchiectasis, with an adjusted odds ratio of the high viral load ranging from 12.4 in hospital studies to 14.4 in a community setting, really just demonstrating that Alice Springs Hospital is a community hospital. And background rates of ham uveitis, IDH, and myositis. So we also see neurology, though, and this has been reported in Brazil, numerous studies, that just doesn't fulfill criteria for ham. And that's been published in CID last year. An increased risk of death with high proviral load of adjusted hazard ratio of nearly 4. So with this in mind, the Australian prevention policies and guidelines have been relatively slow in coming. Certainly blood donor screening was introduced in the early 90s, and occupational exposure for follow-up of healthcare workers was introduced nearly 10 years ago. And this includes antiretroviral therapy in our setting. Surveillance is really only done in the Northern Territory, and that's for individuals with their first diagnosis of HTLV1 and also for a diagnosis of ATL, but there's no attempt to prevent transmission really within the highly endemic areas that we have in Central Australia. So in terms of mother-to-child transmission, and also HTLV1 is really not part of the bloodborne virus or STI policy. So in understanding this, we need to go to the Communicate with HTLV1 Consultative Forum that occurred in 2018. And this really suggested that only in a small proportion of people after many decades, HTLV1 causes a rare form of leukemia and or spinal disease. So other associations are suggested, but not really known whether it's causative or not. And the conclusion was there needs to be a major long-term study developed in partnership with the affected communities. And this is what we have. So we have a Department of Health funded longitudinal study, the primary outcome of which is the number of deaths attributable to HTLV1. And the number of deaths, though, that are needed before there is a public health intervention has not been stated, nor is the how the secondary outcomes of HTLV1 associated diseases and other disease associations might impact on that. So I just finally wanted to address some of the barriers to prevention in our setting. And this is work that was actually done by Fiona Fowler for her master's thesis. She's visiting from Berlin last year. She did a terrific study looking at a qualitative study of perceptions of 59 Aboriginal people and healthcare workers in Central Australia, and found that there really is a balance between the assumptions of a medical elite, a local, I should say, medical elite here, assumptions about Aboriginal people, assumptions about clinical and ethical issues that pertain to HTLV1, and the need for Aboriginal voices from communities, so real community voices, having some difficulty entering that conversation. So assumptions about Aboriginal people included the thought that Aboriginal people were unable to understand HTLV1, that HTLV1 knowledge might harm Aboriginal people, that HTLV1 was not a priority for Aboriginal people, that treatable diseases, so diabetes, chronic kidney disease, etc., are more important to communities, views of Aboriginal people generally being sought through umbrella organisations due to concerns about their health literacy. Ethical concerns, particularly around the one-way information sharing, so there's no consideration of benefit to patient or public. Competition with high burden of non-communicable diseases such as diabetes, hesitation about testing and information sharing without having therapies to offer, and that's targeted therapies for HTLV1, the virus itself. Disregard for available evidence and clinical guidelines, and a perceived medico-legal impunity in our setting. Clinical assumptions are typically that HTLV1 is not clinically significant, that perfect epidemiology is needed to prove these disease associations, that mortality is the best measure of the impact of HTLV1, and that deaths due to ATL are rare in any case. Our discordant perceptions complicates this further between hospital specialists who tend to regard HTLV1 as an issue and those primary care physicians who work in the community. And against this are the concerns of Aboriginal people who are suffering the effects of colonisation, living in a marginalised situation in a complex environment, cultural sensitivities regarding the modes of transmission, gender issues and sexual health, limited access to safe breast milk alternatives, and the potential for stigmatisation from contact tracing of sexual partners. So I just wanted to conclude by mentioning some of the thoughts that came out of Fiona's thesis. And one remote primary care physician, for instance, was concerned that it might be time to take the colour out of it and really, what would we seriously be doing if this was happening in Sydney? Another primary care physician tries not to talk about HTLV1 because there are more important things to talk about. And this is balanced against the views of Aboriginal people who have a lived experience of HTLV1. So this is a statement by a man living in a remote community where a community resident had died with ATL some months previously, and to him, our people don't even know about that. You know, it's the virus, like a ticking time bomb. And obviously HTLV1 testing not being done in these communities with no education, and people having a relative or a loved one dying with ATL or HTLV1 associated disease, and then waiting for someone else to potentially go down the same path. Finally, a woman based in town said, if you give us the information, everyone talks about this. Education is power. And I'll stop there and just acknowledge the many people who've supported my work over the last 16 or so years. Thank you.
Lloyd, thank you so much for that. So many issues. There's the problems that you're facing are obviously particular to your setting, but they also resonate. Many of the issues resonate across many other communities, and I suspect we're going to come back to that as we get further on into the session. It's now my pleasure to introduce Professor Angelica Miranda. Professor Miranda is the Professor of Social Medicine at the Federal University of Espírito Santo and is the coordinator for sexually transmitted infections in the Brazilian Health Ministry. Professor Miranda is going to talk on public policies for HTLV1 and 2 in Brazil, which I think is an area of movement. So I'm looking forward to hearing from you, Angelica.
Hi, Graham. I hope. Yes, can you hear me? I think I'm having problems.
Yes, I can hear you, and
I
think
I'm going. Oh yes, I think I'm going to speak in Portuguese once there is translation. Okay.
Yes.
I'm going to share my screen.
So, just a reminder to go to the globe if you need to listen to this through translation. Thank you.
Yes. Can you see my screen?
The screen's there. Lovely. Thank you.
Okay, thank you. Isso. Bom dia a todos. Eu gostaria de agradecer a oportunidade de estar aqui discutindo com vocês esse tema tão importante. E hoje a minha fala é sobre as políticas públicas para o HTLV, isso no Brasil. Esses dados são do último relatório mundial da OMS, e eu resolvi trazer aqui para contextualizar a fala, porque as mais recentes atividades que a gente tem proposto no Brasil são baseadas, isso é exatamente nesse relatório. E aí a gente vê que o HTLV é um problema de saúde pública na maioria dos países. As principais vias de transmissão são a sexual, parenteral e de mãe para filho, principalmente por meio da amamentação. E a maioria dos países, principalmente os chamados desenvolvidos, eles já introduziram a triagem do HTLV para as doações de sangue. Agora, poucas outras medidas têm sido incluídas para implementação, para prevenir a infecção pelo HTLV, principalmente em relação ao ATL e à RAM. Além disso, ainda tem muitas lacunas que são lacunas importantes na epidemiologia da infecção pelo HTLV, o que causa dificuldade para avaliar a real carga da infecção nessa população. Em geral, há políticas de intervenção destinadas a prevenir a transmissão do HTLV, como a triagem de doações de sangue, de leite materno, triagem de tecidos, de células de doadores, só que a gente ainda falta alguns dados sobre a epidemiologia do HTLV. E isso é importante porque nós não temos nenhuma intervenção específica no Brasil para falar sobre a transmissão sexual ou pela transmissão por meio do uso de drogas injetáveis. No relatório da OMS, a gente pôde ver que, na região das Américas, o Brasil está incluído com outros países quando fala da testagem para todas as doações de sangue. A mesma coisa em relação ao screening, ao rastreamento na região das Américas para evitar a transmissão vertical do HTLV, que ocorre principalmente pela amamentação. Só que, como coloca o Brasil aqui, a gente já tem esse adeno que isso ocorre em algumas regiões. Então, essa recomendação para triagem no pré-natal ainda não é uma triagem universal no Brasil, mas ela tem ocorrido em alguns estados. E por que é importante a gente estar falando ou estimulando essas políticas no Brasil? Porque o Brasil é um dos países endêmicos para a infecção do HTLV. Então, é importante a gente estar atento a essas medidas para que se possa estimular a execução dessas medidas. O que dificulta a instituição dessas medidas para HTLV no Brasil de forma universal? Primeiro, faltam dados. A gente tem poucos dados sobre como que é a real situação da infecção pelo HTLV no país. O que tem nesse gráfico é a taxa de prevalência da infecção pelo HTLV em doadores de sangue em 12 capitais. O que isso importa? A gente não sabe aonde estão em branco qual é a real situação desses estados. Então, algo importante para estimular essas políticas é a gente dar visibilidade, estimular estudos de prevalência, para se conhecer qual é a carga do HTLV no Brasil. Isso já tem sido feito de forma tímida, mas já há muitos anos. Desde 1993, que o Brasil estabelece o rastreamento de todas as doações de sangue no país. E aí, a gente vem acompanhando, tiveram alguns manuais, alguns relatórios propostos pelo Ministério da Saúde. Desde 98, quando veio um relatório específico para a hemoterapia, mas em 2002, um protocolo onde se indicava qual seria o melhor manejo clínico para o HTLV no Brasil. A segunda edição veio em 2013 e a terceira edição, isso foi lançada, na verdade, este mês está sendo lançada a terceira edição desse manejo clínico. Só que ao longo dos anos, a gente tem visto que tem pouca coisa acontecido, como o rastreamento de doadores de órgãos, de tecidos ou de células em 2019. Em 2014, foi lançado um guia para como conduzir o recém-nascido. Um marco importante que, na nossa opinião, ocorreu foi em 2019 ter sido criada a coordenação específica para infecções sexualmente transmissíveis e nessa coordenação foi incluído o HTLV. É como se no Ministério da Saúde do Brasil agora o HTLV tivesse uma casa, né? E todas as medidas, todas as implementações estão sob a responsabilidade da coordenação de IST. A Carolina Rosadas publicou um artigo recente falando dessas políticas públicas que já estão no Brasil e o que a gente tem proposto. Então, a gente já viu que o rastreamento de doadores de sangue, de órgãos, algumas estratégias para redução naquelas pessoas que são usuárias de droga injetável, sendo que a gente sabe que isso principalmente no contexto da infecção pelo HIV. E o que precisa? O que agora a gente tem tentado trabalhar? Na introdução de testes confirmatórios para todas aquelas pessoas que são doadores de sangue e que só é feito o rastreio. Isso ainda é uma proposta. Na transmissão sexual, a gente tem tentado estimular desde a inclusão de um capítulo de HTLV no protocolo brasileiro de IST, isso tem a iniciativa de se dar mais visibilidade ao tema. Como a gente já tem o HTLV em doadores de tecido, como um critério de exclusão para doadores de gametas. Nas campanhas de IST tem se falado de HTLV, e isso é uma surpresa para nós, mas algo muito importante, porque vários profissionais de saúde começaram a se interessar e escrever para o Ministério querendo saber mais sobre o HTLV. Agora, o que precisa ser feito? A gente precisa estimular a implementação a nível universal dessas propostas, como a inclusão do HTLV na testagem de rotinas para pacientes com IST. Aqui, em relação à transmissão vertical, né, já há uma recomendação desde 2019 no Protocolo Brasileiro de Transmissão Vertical para se evitar o aleitamento materno em gestantes com HTLV, como também o Ministério da Saúde colocou dentro do programa de HIV, que já era feito, a provisão de fórmula láctea para aquelas mães positivas. Isso não ocorre ainda de forma universal no país, mas já está implementado em vários estados. A gente tem algumas coisas importantes a ser feitas, né, como a notificação compulsória, pelo menos das gestantes, é algo que o Ministério da Saúde está trabalhando com a sociedade científica, com a sociedade civil, porque a gente considera que só um trabalho em conjunto a gente vai conseguir fazer essa implementação, tanto do teste confirmatório, como da oferta de teste de rastreamento para todas as grávidas no país. Essas medidas são mais complexas para nós, porque o Sistema Único de Saúde, que é o sistema público de saúde no Brasil, uma vez que tenha uma recomendação do Ministério da Saúde, o governo precisa pagar por todos esses testes. Então, isso tem que passar por vários processos dentro do Ministério da Saúde para que a gente consiga. Mas o fato de ainda não ter saído não quer dizer que nós não estamos tentando. Isso tem sido feito e estimulado desde 2019. E a gente viu o quê? Para a implementação dessas políticas, para que ganhar a sensibilidade das pessoas, a gente precisa divulgar e colocar o HTLV na pauta. Então, isso foi importante, essa inclusão de um capítulo do HTLV dentro do Protocolo Brasileiro de IST, e para que se possa dar mais visibilidade, o protocolo clínico foi publicado em formato de artigos na revista Epidemiologia e Serviços de Saúde, que está disponível em português e espanhol, e também na revista da Sociedade Brasileira de Medicina Tropical, que publicou todo o protocolo em inglês. A ideia é para facilitar que o profissional de saúde tenha acesso à leitura de capítulos separados, e nesse sentido o capítulo de HTLV. Porque a educação em saúde, tanto dos profissionais como da sociedade, é muito importante para a gente dar visibilidade a essa causa. E aí, nesse sentido, foi feito também um fluxograma, que o fluxograma de IST, e a gente tem 2 páginas sobre o HTLV, com a sugestão do fluxograma para fazer o diagnóstico laboratoriais da infecção causada pelo HTLV. Então, mesmo que ainda não seja pago pelo Sistema Único de Saúde, a gente já tem uma sugestão para o profissional de saúde em relação ao rastreamento, ao diagnóstico e ao tratamento das complicações. Nesse mesmo sentido, foi produzido um curso de atenção integral às pessoas com infecção sexualmente transmissível. É um curso autoinstrucional com 90 horas, ele já está disponível na plataforma AvaSUS desde julho de 2020, e já tem mais de 4.000 profissionais de saúde envolvidos e registrados para fazer esse curso. Dentro desse curso, a unidade número 11 é um capítulo só sobre o HTLV, onde foram convidados especialistas de HTLV no Brasil para que fizessem a preparação da discussão. Desde 2019, a gente tem incluído o HTLV na discussão das campanhas para a sociedade em geral. Então, essas últimas 2 campanhas, essa aqui, que está o Dia Mundial de Combate contra o Vírus de HTLV, é a campanha que está sendo lançada hoje, que vai colocar em todas as redes sociais do Ministério da Saúde, falando do HTLV, falando onde procurar ajuda ou como falar sobre HTLV. Essa outra, usar camisinha é uma resposta de todos, foi a última campanha, anterior a essa que está sendo lançada hoje. E em relação à discussão mais direta com os profissionais de saúde, a gente planejou ter uma discussão presencial, mas por conta da pandemia de Covid-19, essa discussão passou a ser online, e aí nós tivemos uma discussão sobre o PCDT de IST, e uma das discussões foi sobre o HTLV. Foi uma discussão com muita participação, teve participação de pessoas até de fora do Brasil, e a ideia de todas essas ações é a gente estar fazendo uma mobilização para colocar o HTLV na pauta da saúde pública brasileira. Este mês foi lançado também o protocolo clínico de HTLV na sua 3ª edição. Há um processo no Brasil que a gente chama do protocolo clínico e diretrizes terapêuticas. Para que isso seja colocado, ele tem que participar de uma consulta pública e ser colocado na Comissão Nacional de Inclusão a Tecnologias em Saúde, a nível do Ministério da Saúde, na Secretaria de Ciência, Tecnologia e Inovação. Inicialmente, a revisão desse guia já planejava ser esse protocolo final de diretrizes. Só que, como eu comentei anteriormente, o custo é muito alto. Então, nós fomos orientados a fazer parte a parte, então tem o guia que vai servir de todas as evidências científicas, e já tem sido discutido e colocado em pauta junto com a Conitec, capítulo a capítulo, para que essas incorporações sejam feitas devagar. Então, a primeira provavelmente vai ser a testagem de HTLV durante a gestação. A gente acha que deveria entrar na rotina com todas as outras sorologias, com todos os outros testes que são feitos, também que a gestante, na sua primeira consulta pré-natal, fosse testada para HTLV. Lembrando que a nossa preocupação principal é em relação à transmissão por via de aleitamento materno. Mas a partir da incorporação da gestante e na sequência de algumas ações em relação à RAM e à ATL, que algumas já estão no Brasil, e já estão incorporadas pelo Sistema Único de Saúde, mas elas se encontram pulverizadas em várias recomendações. E a gente queria ter uma proposta única onde tivesse todas as ações relacionadas ao HTLV em um único documento. Então, é esse processo que tem sido feito agora, e a divulgação, colocação dessa infecção na pauta é muito importante para que a gente ganhe a sensibilização da sociedade como um todo, além dos profissionais de saúde. Então, em resumo, o que nós temos? Nós estamos trabalhando com uma política nacional para a prevenção da transmissão do HTLV, já se tem o rastreamento de doadores de sangue, de órgãos e tecidos, a exclusão de pessoas na hora de doação de gametas. Já temos HTLV em gestação em alguns estados, já temos alguns estados no país que fornecem, mas ainda não é uma política nacional. Ainda não há um consenso no Brasil sobre a testagem de crianças nascidas de mães HTLV positivo, em como fazer esse acompanhamento. E o nosso próximo passo é continuar a dar visibilidade a essa infecção, para que medidas sejam feitas, sejam estimuladas no país, e a nível real, é a inclusão, a nível do Sistema Único de Saúde, da recomendação da testagem de mulheres grávidas para o HTLV. A gente espera que no próximo ano isso já tenha se tornado uma realidade, que no próximo dia 10 de novembro a gente já possa falar dessa incorporação como algo real a nível universal no Brasil. Eu acho que por hoje era isso, e estou aqui à disposição para discussão. Muito obrigada, Graham.
Thank you, Angelica, and so thank you to the translators. Keeping up. So there's some real progress there, and I'm sure we'll come back to that. And I think, from my perspective, Brazil is going to have to be, to some extent, a global leader in public policy, and I think you're already moving in that direction, and the rest of us are going to have to jump on your tailcoats. So it's not before time that we heard from people who are living with or burdened by HTLV on the present situation regarding HTLV. And I'd like to introduce 3 panelists. Ms. Agine Oliveira, who's a Bachelor of Psychology and a member of the association HTLV from Bahia in Brazil. Also, Miss Emma Moyano, and who's a representative of people, patients living with HTLV in Argentina. She is herself living with HTLV, and she tells us she's 47 years old and is born in a non-endemic area for HTLV, but has a large group of members, and a large number of the members of her family are in fact living with HTLV as well, and 2 of her brothers have actually died from adult T-cell leukemia. So a real impact in a very personal way. And then finally, Mrs. Christy Blakeborough, who since being diagnosed with HTLV-1 in 2010 has spent the next decade or so making her voice heard. As a patient representative, she's spoken at the International Retrovirology Association conferences and the European HTLV Research Network meetings in Rome, in Bucharest, in Martinique, in Lima, and was a member of the working group that met with the WHO 2 years ago in Tokyo and discussed and agreed the wording and the recommendations of that report that was published earlier this year. She's also a co-signature on the letter to the Lancet that really sparked all this present activity, for which we're so grateful. She's proud to speak up for people living with HTLV around the world, and I think is going to continue to do so. So I'm going to hand over to the 3 of you to give your perspectives, please. And you have about 15 minutes. We've got a little bit of extra time, I think. So please do take that now, and I will reappear on your screens in about 15 minutes or so, just to let you know how we're doing with time. Thank you.
Olá, pessoal, bom dia. Estão me escutando?
I can hear you.
Primeiramente, eu gostaria de agradecer ao Ministério da Saúde do Brasil, na pessoa da doutora Angélica Miranda, agradecer à OPAS por unir forças nesse objetivo de pensar políticas públicas para o HTLV. Agradecer também ao canal HTLV, doutora Carolina Rosadas e Tatiane Assoni, pelo excelente trabalho que elas vêm fazendo. E tenho 2 agradecimentos especiais, né, a todos os pesquisadores que, mesmo com todas essas dificuldades, nunca desistiram de estudar HTLV, e deixar aqui meu abraço de esperança para todas as pessoas que vivem com HTLV e acreditem que dias melhores virão. Meu nome é Adjane Oliveira, eu sou bacharel em psicologia, desenvolvi mielopatia associada ao HTLV, participo da Associação HTLVida e posso dizer com todas as letras que minha vida mudou muito desde os primeiros sintomas do HTLV. Mesmo assim, eu ainda me considero uma pessoa privilegiada, porque desde a adolescência eu soube que eu tinha HTLV, mas isso não é a realidade para a maioria das pessoas. O diagnóstico positivo, ele é totalmente desconhecido da população geral, e principalmente, dos profissionais de saúde. E isso, gente, é assustador. Eu considero o desconhecimento do HTLV o maior complicador. As pessoas peregrinam em busca de diagnóstico e acompanhamento. Diante desse triste cenário, em 2010, foi fundada a Associação HTLV Vida, por influência do Dr. Bernardo Galvão, e com grandes objetivos, né? Divulgar o HTLV e contribuir para a criação de políticas públicas eficazes para as pessoas que vivem com esse vírus. Desde então, não paramos. Somos um grupo com grandes limitações motoras, né? A maioria com bengala, andador, e devido à pandemia, a gente já está seguindo realmente para a cadeira de rodas, mas a gente tem uma vontade enorme de colaborar para que a gente tenha um futuro menos doloroso, né, com essa vivência do HTLV. Estamos fazendo o impossível para ocupar todos os espaços, falar de nossas dificuldades em todas as instâncias, isso é municipal, estadual, nacional e até internacional, como a gente está falando aqui hoje. E a gente sempre vem provocando, trazendo propostas e, às vezes, fazendo até o papel, né, dos órgãos que ainda desconhecem o HTLV. Nossa maior conquista aqui no nosso estado da Bahia foi uma portaria em 19 de novembro de 2020, que implanta a linha de cuidado integral às pessoas que vivem com HTLV. Isso é um marco, não só para o nosso estado, mas para todo o Brasil, porque a gente acredita que, a partir dessa linha do cuidado, todos os outros estados possam contribuir, replicar essa linha de cuidado e assistir melhor essas pessoas que vivem com HTLV. Ainda precisamos avançar muito no desenvolvimento e na implementação de políticas públicas de saúde direcionadas ao HTLV, mas eu tenho certeza que a gente aqui na Bahia só conseguiu avançar porque a gente está unido, a gente caminha junto. Eu me refiro à união dos pesquisadores baianos e brasileiros, ao governo municipal e estadual, ao nacional e a incansável luta, gente, da sociedade civil. Vivíamos totalmente invisíveis aqui, né? À margem da sociedade, ninguém falava de HTLV e ainda é gritante a necessidade de divulgação do HTLV. Precisamos, principalmente, de ampliar essa discussão e trazer essa informação para os profissionais de saúde, investir em diagnóstico precoce, teste rápido para HTLV, acesso aos serviços especializados com profissionais que tenham expertise nesse vírus. Precisamos barrar urgentemente a transmissão vertical, garantir fórmula láctea para essas crianças, filhos de mães com HTLV, e dar assistência a quem precisa. E não esquecendo, principalmente, de investir em pesquisas para antirretrovirais e vacinas para HTLV. O HTLV, gente, me trouxe muitas perdas. Eu deixei de trabalhar em algo que eu gostava muito. Fui obrigada a me aposentar muito cedo. Vivo com limitações impostas por esse vírus. E, infelizmente, toda a minha família, somos 6 integrantes, agora 5, vivemos com HTLV. E a incerteza de que meus familiares possam desenvolver algum sintoma desse vírus, isso me assusta muito. E, diante disso, eu faço parte dessa associação e que todo dia pessoas de todo o Brasil buscam informações e atendimento. Há 2 anos atrás, eu vi meu irmão, sem nenhum sintoma, falecer por leucemia linfoma. Isso tudo muito rápido, em menos de 1 mês, meu irmão começou a desenvolver os sintomas de leucemia e acabou falecendo. O HTLV até hoje vem vencendo essa guerra. Com isso, a gente aumenta estereótipos, estigmas, preconceitos, julgamentos e falta, né, rede de apoio. Somos pessoas que vivemos com medo da quebra do sigilo. São muitos casos de pessoas abandonadas e solitárias. É muito triste viver com HTLV num país tão cheio de desigualdades e injustiça social como o Brasil. Nos sentimos culpados e, por medo das rejeições e constrangimentos, omitimos o diagnóstico. E, dependendo do grau de limitações causadas pelo HTLV, eu afirmo, estamos totalmente isolados do convívio de familiares e convívio social. É um sofrimento psíquico enorme e eu posso dizer também, existe uma morte social para as pessoas que vivem com HTLV. Então, meu apelo final é para convocar todos a pensar, a criar, a instituir políticas públicas eficazes no enfrentamento desse vírus que mata e traz tantas repercussões negativas. Muito obrigada.
Thank you so much, Jen, for that impassioned and touching account and making that voice clear. Who's going next? Is it Emma or is it Christy? Emma, I think.
Hola.
Hola.
Hola, soy Emma Moyano, representante de pacientes de HTLV vivo con HTLV1. Para nosotros es muy importante que se realice este foro, ya que necesitamos de forma urgente que incluyan al HTLV en un programa de salud para poder hacer seguimiento y también capacitar a profesionales. Muchas gracias por la invitación. El HTLV viene afectando a mi familia desde hace más de 200 años. Fue pasando por generaciones a través de la leche materna. En Argentina el HTLV es endémico en 2 provincias, Jujuy y Salta, pero circula en todo el país y puede afectar a la población en general. Este es el caso de mi familia. Somos 10 hermanos nacidos en un lugar donde el virus no se conoce, 9 vivimos con HTLV, 2 fallecieron por ATL en el año 2018. Después del fallecimiento de ellos nos hicimos el test confirmatorio. Ese mismo año se hizo la presentación de la carta dirigida a la WHO, a la OMS, que dio una gran movida y visualización a nivel global que llevó a realizar con mucho esfuerzo reuniones con la WHO y representantes internacionales en HTLV. Luego de mucho esfuerzo se logró incorporar a la HAM al Manual de Código Internacional de Enfermedades, CIE, pero aún falta que incluyan la palabra HTLV al mismo. De todos modos, hoy no existe un programa de salud que incluya el HTLV. Es muy importante que en estas reuniones estén presentes referentes de todos los países donde circula el HTLV y también los pacientes. Nosotros podemos aportar mucho desde nuestro lugar, ya que lo vivimos y padecemos a diario y también aportamos sentido común. Les agradezco por esta oportunidad que me dieron de poder expresarme y participar. Hoy la mayoría de las veces que voy a diferentes especialistas en salud tengo que explicarles yo qué es el ATL. Es retraumatizante tener que hacerlo. Llevo los papers para que sepan qué síntomas monitorear y cada cuánto deberían hacer los estudios de seguimiento. Es muy importante que la WHO incluya el HTLV en el programa de enfermedades de transmisión sexual, para que cada vez que se pida un test de enfermedades infecciosas también se pida el test para HTLV. Recordemos que solo se encuentra HTLV buscando al virus HTLV, como ocurre con el HIV. En Argentina se hace el test de HIV, sífilis y enfermedades de transmisión sexual en los 3 trimestres del embarazo, pero falta el HTLV. En caso de ser positivo, debería no amamantar para evitar su transmisión, ya que hoy es el principal fuente de contagio. Pienso que la HTLV no califica en el programa de enfermedades poco frecuentes, ya que ellas no pasan de las 3 cifras y nosotros somos millones. Si bien el HTLV produce 3 enfermedades específicas, nos hace propenso a desarrollar enfermedades autoinmunes, cardíacas, pulmonares, diferentes tipos de cáncer, infecciones oportunistas, lesiones en la piel, que es un aviso de comienzo de ATL. Hoy sabemos que existe el síndrome intermedio en enfermedad neurológica que deriva, entre otras cosas, en incontinencia urinaria. En Argentina, desde el año 2005, se realiza el tamizaje obligatorio en donantes de sangre, órganos y plasma. Todavía nos falta una ley para que se haga el testeo en bancos de sangre, y en bancos de leche y en neonatologías. Por favor, no pongan obstáculos, que nosotros somos los que ponemos el deterioro de nuestra salud y la muerte. Muchas gracias. Háganos visibles.
Thank you, Emma, and thank you also to the translator who added not just the words but the passion to that, and some real messages of importance, which I'm sure we'll come back to. We've heard before, particularly on the question around ignorance amongst health professionals. So, Christy, over to you.
Thank you, Graham. Good morning, good afternoon, good evening to everybody who's on this call. Currently showing 246 participants, which is amazing. So I'd like to say a huge thank you to the organising committee for asking me to participate in this World HTLV Day event. As many of you know, and as my introduction said, I've been speaking passionately as a patient representative for many years now. And I feel huge responsibility and weight of expectation from the millions of people living with HTLV across the world, as so many voices simply are not heard. I feel privileged to be speaking on their behalf. I'm speaking to you from my workplace. It's no coincidence that I've chosen to be in my office today, as I've worked in conjunction with colleagues to release a World HTLV Day blog on our intranet. To say I feel confident and supported enough by my colleagues to be able to do this is a huge step forward for me. And I'm looking forward to many more HTLV related conversations in addition to the ones I've already held today. Wearing a t-shirt with it written on always helps. I think of all the people living with HTLV around the world and know that I personally am lucky. I'm invested in my healthcare. The HTLV clinic at St Mary's in London is world leading and hugely supportive of its patients. And I've been able to make lifestyle decisions based on my diagnosis. However, I'm an individual. I am outspoken, and I know my own method of dealing with my diagnosis is simply not possible for the vast majority of people living with HTLV to replicate. It's tiring to constantly acknowledge the disease and its impact, from the self-stigmatization to the isolation, to the complicated healthcare regimes faced by those with HAM-TSP, ATL, or other health issues. There can be solace and camaraderie in the people living with HTLV community, but this is so often hard to organise and maintain as a group of disparate individuals brought together by what can rightly be described as a negative circumstance. In the UK, we have seen patient fora come and go, as unfortunately the burden of negativity can just be too much for peer-to-peer support. We've recently had a series of patient workshops organised from St Mary's, of which I was able to attend some due to work commitments. And these highlighted to me the fundamental issues so many of us still face. Access to basic coordinated care packages and mental health support for those of us who struggle with our mental health far more than any physical impact of this disease were the main requests I discussed with other patients, some of whom I hope are on this call today. I know I'm not alone in having to explain what HTLV is to medical professionals time and time again as they care for some aspect of my health. It shakes your fundamental reassuring belief that you are in the hands of a trained professional who will make things better if you have a greater knowledge of HTLV than they do. So what can we do as people living with HTLV? We can attend appointments. We can volunteer when trials require us to, whether it be a desk-based questionnaire, which I know the HTLV register sends out in the UK, or perhaps a more intrusive morning spent testing nerve reflexes and having skin biopsies taken. An extra vial or two of blood given at our monitoring appointments when requested. These may seem like small steps, but too often patient cohorts for analysis are too small and more people are needed for real scientific results to be concluded. As a wider group, we can be less afraid to talk about HTLV to our peers. This may be easier said than done, but if we keep our light under a bushel, no one will notice when it goes out. This includes our general practitioners in the UK. Only yesterday, I attended my new practice and found my new GP Googling HTLV as I walked into my appointment. He might have found some of my previous posts. We can encourage these frontline professionals to engage with our HTLV clinicians to ensure that care is joined up. We can also encourage them to take an interest in the increasing number of scientific papers published about HTLV as research goes forward. Whatever we do, the aim is bit by bit not to be the anomaly, for people to know what HTLV is when we talk about it. And as HTLV begins slowly to move into the public sphere, we can find a voice when patients with rare diseases are invited to formulate action plans. We also want our GPs or those healthcare professionals we have regular contact with to feel empowered and knowledgeable enough to include HTLV in local plans and policies they fade into, and then to push up to regional and national level. The meeting in 2019 in Tokyo with the World Health Organization was a huge step forward. For me, it was life-changing. A report from that meeting output is hosted on the WHO website. But there is still much to do. But we are there on the world stage, and we can together push forward to ensure future generations do not face the same struggles we have. We are not alone. One person's battle is every person's battle. Thank you.
Thank you, Christy. So we're going to move to our Q&A, but I think I'm going to take chairperson's prerogative here and jump in with a couple of slides of which I was going to save to the end, but I think they might help to link some of the things that we've talked about, and then we'll come back to some themes. So whilst I'm sort of organising that, just to remind everybody that the Q&A is the place to put the questions. I'm not sure how good I'm going to be at spotting hands up amongst 246 people. So please, if you can write your question, we've got some in all three languages at the moment. I've had them translated, so I'll be able to read them out. And but just if I'm going to share my screen now, hopefully. And I'm still seeing, okay, there we go. So find a window. Oh, now I'm not sure if my slides showed there. Do my slides show?
No.
Or not? No, hang on. I might have to do something. Sorry about this. Everything's decided not to respond. That says you can now see my screen, but you may actually. I can't see my screen. That doesn't help. Okay, let me just talk through one thing I was just going to say towards the end, but I think Dr. Jack will finish this session this morning very nicely, and so one of the things that when I was thinking about the how, and I think we've been hearing about it this morning, this afternoon, this evening, the things that are said, which I think are myths, and I think there's a duty on us all, whether we're speaking out or we're writing, that we start to be uniform in putting some of these myths to rest. So I'm just picked out some of the things that were in the reasons why the National Screening Committee in England in 2017 and in 2012 decided there was no need or no justification to do antenatal screening. And at the top of the list, it says HTLV rarely causes disease. And I think we sometimes find ourselves writing papers that alludes to that or suggest that, you know, very few people get disease. Most people are asymptomatic. There's enough data out there to debunk this myth. There's enough data there now to say not only are there overt diseases, but there are other impacts that we don't yet fully understand the how or even the degree to which people are impacted. So this is a call to all people who write medically to make sure that we correct this perception of HTLV rarely causing disease. The second one is that not many people are infected, and they were talking about that from a UK perspective. But how many is not many? As Lloyd was saying, you know, you've got to put a number to what you need to justify your program. But if you don't specify what that number is, how do you know what the results are going to be? We estimated 2 decades ago there were 20 to 30,000 people with HTLV in the UK alone. And then there was a question of, since there's no treatment for the mothers, we shouldn't test for it. And we often get these questions about, well, what will be the impact of being tested on the mother's mental health during the pregnancy? Nobody asking the question of what is the impact on their mental health, their anxiety, their joy, if the testing of a baby is found to be infected later, after the opportunities to prevent transmission have been missed. We were told that we don't know whether the diagnostic tests in pregnancy work, when there is a vast amount of data on antenatal screening. And the one that really I found particularly hard to grasp was the fact that because babies don't get sick, so antenatal screening is not important. And I just don't understand where that suggestion comes from. We don't just screen for infections that present in, or even diseases that present in infancy. And the second point I was going to really draw attention to is the vast tracts of the world which on the maps that we have of where is HTLV are marked in grey, and you know, billions of people where we don't know what the prevalence of HTLV is, and it seems unlikely that HTLV is not prevalent in those areas to some degree. We in London have such a mixed population, we can see what's happening around the world, and we know that there's HTLV1 in Pakistan, for example, before anybody really published on cases being prevalent there. And even today, I heard about a first diagnosis of a patient from Sri Lanka, which again is grey on the map. So there's a lot of knowledge that we need to disseminate. Yeah.
I am putting your presentation.
Okay, thank you. So I just cancel that. So am I okay to carry on talking here? Maybe I have to start my video. Yeah. So we can see here that all the way across Southeast Asia, totally grey, and then we get to regions of the world where we know HTLV is prevalent, particularly Melanesia and Australia. So big questions as to why we don't know the prevalence in those regions. Regions, some of which have good healthcare systems, we should be able to know more about HTLV in those regions. And then the final, can you move on to the next slide, please? The final point I was going to make was, no, back one, sorry, with this, and I think we focused a lot today on, we've mentioned blood transfusion and blood donor testing. We've looked at mother-to-child transmission. Fabiola mentioned it right at the beginning, but when we come to the one of the ways in which HTLV is transmitted, and probably certainly from data from Brazil is one of the major routes of transmission, which is through sexual intercourse. When we look at the list of infections which are tested for, which are included in people's diagnostic panels, I've put down a whole load of infections here. You will not find HTLV amongst that. So this really is a starting point for me, that if we're not testing, if we're not testing for infection, if we're not testing for disease, then how on earth are we going to come up with policies to tackle the problem? And often we're in denial as to what the prevalence of infection is in our own settings, and therefore we do nothing about it. That's I'm going to leave my slides at that point so we can get into the Q&A and ask all the panelists to come back on video, and we'll start to go through some of the questions. So there was a comment quite early on, which I think maybe one has gone. Is around about the description and in the why as to the many conditions and the morbidity which is associated with HTLV infection. But from a public point of view, we also need to understand what's happening in a sort of more than amongst the sort of asymptomatic setting. So if we're going to address it from a public health perspective, we need to address the asymptomatic infection as well as the diseases. Fabiola, would you? I think you could comment on that.
I'm here, Graham. Though I can't get my camera, it's blocked from the organizer, it says. So Graham, can you say again what you were saying?
So the question was about the focus in the why should we be eliminating HTLV. There was very much on the diseases, but from a public health perspective, it's probably as much as anything those who are asymptomatic that we need to be targeting.
Oh yeah, no, I mean, remember the first thing I said was who wants an STI, so The problem with HTLV is that unlike some other infections, it doesn't cause any symptoms at time of transmission. So even if we compared it to its cousin, HIV, a third of patients will notice a primary infection, a rise in viral load, and have virological symptoms, immunologic, fever-like symptoms, a rash, etc. But HTLV, really, we haven't come across, that I know of, please correct me if I'm wrong, someone who had a seroconversion symptom. So diagnosing it is really difficult. And the problem I think I have, obviously I wanted, identified ASAP, treated, vaccinated, you name it. The problem is that a lot of policymakers, public health physicians, even sexual health physicians, infectious diseases physicians, neurologists, oncologists think it is a harmless virus. And to breaking that myth, it's been your and my and Lloyd and Christie's and all of your life work. It's not harmless, because if you turn the question and say, well, would you want HTLV? Would you mind? Then you see that people are more reluctant to, talk about it in that way. So I think we need to include all people who are, I'm not even so happy to call people who live asymptomatics. I call people now people burdened with HTLV. It's a burden. It's different than people who have HIV. We have moved on and we say people living with HIV, they have treatment. They can live a very healthy life. It's fantastic to look after patients with HIV nowadays compared to when I started. But people with HTLV are actually burdened. It's on their mind. Future is uncertain, etc. So yes, we need to include all people in prevention.
And thank you for that. And something which came out, I think, well, from Christy, who's I think had to leave us, but is the coping side of HTLV and the mental health impact. And we know from our quality of life studies that people who are allegedly asymptomatic with HTLV infection actually have a lower quality of life than some people with who have infections, other conditions which are symptomatic. I wonder, Angelica, can I bring you in on this question around sort of the impact of HTLV beyond the obvious, and how that factors into sort of Brazilian policy? If I'm making myself clear, are people focusing just on cost effectiveness because there's adult T-cell leukemia or there's myelopathy, or is the bigger picture now being embraced? And maybe I can get Lloyd to comment on that as well.
Isso, eu posso comentar com você como tem sido no Brasil, né? Tem várias medidas em relação à ATL que já são pagas pelo sistema público de saúde, só que ficam de forma pulverizada. O que a gente tem tentado fazer agora, e a Tatiana tem ajudado muito, é a gente fazer o mapeamento de onde estão localizados os centros de referência para atendimento desses pacientes. Porque uma vez que a gente conseguir localizar isso, onde eles estão sendo realizados, quais são os insumos que eles têm disponível, a partir daí, eu acho que o Ministério da Saúde não é nem a nossa secretaria, é a Secretaria de Assistência Especializada em Saúde, vai ser provocada para que faça uma implementação desses serviços. E uma outra coisa importante é saber se eles estão distribuídos em todos os estados da federação. Porque se há alguns estados que não têm esse serviço, a gente tem que providenciar para que eles estejam disponíveis também lá. Isso tudo é um processo no Brasil que é um pouco complexo, porque todas as coisas que são recomendadas, todas as tecnologias, os insumos que são recomendados pelo Ministério da Saúde, o governo precisa pagar por eles. Então, isso todas as vezes que é proposta uma nova intervenção, como a que nós estamos querendo fazer agora, de incluir a testagem universal no pré-natal do HTLV, ele precisa passar por uma comissão que vai fazer a avaliação de quanto isso custa para o país. Qual é o custo-efetividade dessa nova tecnologia? No caso da gestação, isso está bem adiantado, inclusive por conta de um artigo, de um trabalho que a Carolina Rosadas está fazendo, ou já até terminou, né, Carol? E isso vai nos dar subsídios para poder fazer a implementação. Agora, em relação às complicações, nós temos que fazer, o que está sendo feito já, esse levantamento de o que já é ofertado no SUS, para ver o que falta e quanto custaria a gente fazer uma implementação universal dessas outras tecnologias. Eu não sei se eu respondi ao seu questionamento.
No, it's helpful. I mean, cost is always an issue with whichever way we look at it. No health system has got unlimited resources, and I guess one of the problems we faced with HTLV is its perception that it's the cost of improving people's healthcare with HTLV is much greater than maybe there are other targets, perhaps where people want to put their money to get their results. One of the things I wanted just to say about the involvement of WHO in the whole process now is that they've added HTLV to the remit of those involved with HIV, hepatitis B, hepatitis C, and sexually transmitted infections. And I think this will be a great thing, because when you're now considering any of those issues, you have to consider HTLV as well. And I think we have missed so many opportunities in the past of not even asking what would be the benefit of this for HTLV, or could we, if we're doing PrEP, for example, are we choosing a drug that could also prevent HTLV? If we choose correctly, we may be able to get public policy to just tweak slightly so that we have an impact in HTLV, which we could miss simply by not asking the question. And I think it's so important that WHO are now embracing HTLV, and so putting it on their agenda and incorporating it in the same way that you're looking at it in Brazil and saying, what can we do when we're thinking about STIs? We have to add HTLV to it. And there was a comment in the Q&A just now from somebody saying they thought they'd looked after their sexual health well, they'd taken care of it, they were having checkups, and they feel let down because they were not screened for HTLV. And of course, and probably just about every sexual health clinic in the world, you go for a checkup, and if you're told, it's all get a good bill of health, but nobody's told them what they haven't tested for, and they haven't told them they're not testing for HTLV. So we have to get people aware that there's even HTLV to be tested for. Now, I'm going to have another look at the questions. There was one. This is a virological question. I was told my lymphoma started with HTLV. After 6 months of treatment, I'm told it's in remission. I've also had a bone marrow transplant. How do I know if I still have the virus? That's probably actually a question for me. You don't know unless it's measured. So we can look directly for HTLV in the blood post-transplant. We need to wait sufficient time to know that the transplant has properly engrafted, and we can look and see whether the transplant has eliminated the virus as well as the lymphoma. But it also raises a point which is, are we doing anything to prevent people who are going down the transplant route to prevent their donor cells from being infected with HTLV1? We do that in the UK. We recommend an integrase inhibitor. And I'm just going to follow on from that with a question that Herdela put to you, Lloyd, around the treatment offered to healthcare workers who may have been exposed.
Thanks, Graham. I find that fascinating that we don't offer any treatment or testing to a marginalised population in a highly endemic area, but we worry so much about post-exposure
Dr. Lloyd, could you open your camera, please?
Sure. Yeah.
Yeah, thank you.
So it is fascinating, and the odd thing about it is it's actually driven, I think, mostly because the risk here is very low. You know, that there's been one case report that I'm aware of from Central Africa, I think, in a nurse who'd returned to Belgium. But other than that, there's no very little evidence that it's a high risk with general work in the healthcare setting. So, and nevertheless, we have people who are very fearful of contracting this virus. And it's such a paradox to the public health response in our setting. So the basis of that really comes from Mark Pellegrini's group in Melbourne. Did some work with mice, which hasn't been published yet, I don't think, but it's interesting in looking at integrase inhibitors and also TAF, and certainly able to stop transmission in a humanized mouse model. So it probably does work for individuals who have depends on the level of exposure, and certainly if a surgeon cuts himself in a deep wound where there's a lot of blood, then it's a reasonable thing to do, I think. But a lot of it's driven by fear. I was going to mention, though, Graham, in relation to pushing policy, I think part of the problem there is that we're not coherent as a group, and I think the HTLV1 associated pulmonary disease side of things that following on from that review article that we published earlier in the year, HAPD is not something that's really looked at by most clinics, I think, and yet it is a way of pushing the economic argument. So if you have bronchiectasis, for example, and you get your respiratory physicians to test for HTLV1, I think government will be much more concerned about the cost of HTLV1. It's the same as HAM-TSP. The cost of supporting people with HAM-TSP is phenomenal. So that's probably, and I agree with Angelica, I think that's probably one way of pushing policy.
Yeah. So bronchiectasis is, testing for HTLV has been added to the list of things in the British Thoracic guidelines for bronchiectasis. Thank you, Ricardo. There is a question from Colombia where they are in the process of building the guidelines for HTLV. It's very important to include goals in world public policies for the inclusion of specific goals. And I think, one of the things that maybe we're going to again look to Brazil is to see how you're going to measure effectiveness, and is that part of the policy, and how do we know when we introduce something that it's going to, what's the goal, how many infections do we aim to prevent, or how many, what quality of life are we looking at? How are we going to measure the impact of policy? And if there's anybody, Angelica, I might look to you, but if there's anybody else out there who wants to tackle that question, which is probably the last one of this Q&A. Or do you add audit to the policy? Measurable outcomes.
Essa é um excelente questionamento, Graham. E a gente tem que trabalhar nisso, né? Porque tudo vem envolto com custo. E aí, como fazer se uma política é realmente efetiva ou não? Eu acho que, paralelamente, o que tem que ser feito mais investimento, então mais custos, porque a gente tem que fazer um investimento em pesquisa. Como fazer o monitoramento se a sua política está sendo eficaz ou não? Então, acho que, paralelamente à implementação das políticas, a gente tem que fazer um investimento na pesquisa, porque só a pesquisa vai fazer esse monitoramento e nos dar as respostas se esse custo está sendo bem empregado ou quais as modificações que a gente precisa fazer em relação a isso.
Okay. Thank you. We have reached the end of the Q&A. Thank you to everybody who has spoken already this morning, either in the Q&A or earlier. Every talk has been stimulating, informative, very clear, and challenging. And I'm going to ask Dr. Noreen Jack to take us to the end of this first session on health policies. Dr. Jack, I was delighted to meet her again a couple of years ago in Tokyo, because I knew her from a very, very long time ago. Well, I shouldn't say that, but Dr. Jack is a national of Trinidad and Tobago, and was working in the field in retrovirology then, back in the day. She obtained her medical degree in 1981, so we share that in common, and a master's in public health from the University of the West Indies in 1988, a postgraduate diploma, and then a master's degree in infectious diseases from the London School of Tropical Medicine and Hygiene in 2007 and 10. She's held several research positions, the research fellow in the National Cancer Institute, at the then Peiho Caribbean Epidemiology Center, and a senior medical researcher at the Medical Research Foundation of Trinidad and Tobago. She's now with Peiho, the WHO, as a senior advisor for HIV in the Caribbean office, and has held that position, and has served as their representative for Jamaica, Bermuda, and the Cayman. And she's now the representative of Peiho for Belize. Dr. Jack, can you please, to the question, it's time to eliminate HTLV 1 and 2, tell us the how.
Good. Let me put this into. Good morning and good afternoon, everyone. I hope you're seeing my slides. I'm going to put it into slideshow. I'm not
We are.
seeing.
Yes, thank you.
Yes, but I want to put it into slideshow, and for some reason, I'm not seeing.
If you go down to the bottom of the screen, you can probably see where to click there.
Yeah.
Right on the bottom, about the fourth little icon. Keep going across.
Yes. Good. Thank you. And I need to go up to the first slide. Oh, it shouldn't have done it. Oh. Okay, I think I can go up. Okay, so good morning and good afternoon, everyone. And really thank you very much for the opportunity to be part of this session. I think this morning we had a really stimulating session, a lot of knowledge, and it takes me back to my younger days where I first began doing research on HTLV1. And I say HTLV1, and at that time, we had funding for HTLV1. We did not have for HIV. So some of the work we did for HIV was through funding from HIV. Looking at the prevalence in sexually transmitted disease clinics. We heard this morning the impassionate plea towards elimination, and we were given the reasons why. However, there is a lack of knowledge and understanding of the true burden of the disease. And if you do not look, you will not find. And I think this has been the issue, especially in recent times, related to HTLV1. And the reasons why we need to understand the true burden of the disease is to develop cost-effective prevention interventions. And if we are to move forward towards elimination, they must be cost-effective, and we must understand the true public health impact. And only through the understanding and having these cost-effective prevention interventions, it will enable governments to move forward with adopting policies towards elimination of HTLV. A better understanding, we heard the plea and impassionate plea, especially of Ajin, about the lack of knowledge of healthcare workers. So we need a better understanding by both healthcare workers of HTLV, but also the general population. They are unaware of HTLV. And having better knowledge by the healthcare workers and the communities, we can move forward with better care for people living with HTLV. Now, I think this aspect related to improved testing strategies is really important. So we currently have commercial assays that have high sensitivity and specificity and can be combined sequentially in testing strategies for diagnosis. We have qualitative and quantitative nucleic acid technologies for HTLV1 DNA, but not produced commercially, and they are confined largely into high-income settings. If we are to move forward towards elimination, we need to have low-cost and rapid strategies that can be scaled up to scale up HTLV1 testing. And some of what I am taking here, the lessons learned from our work in HIV, which I also have participated in. We have to have low-cost, rapid strategies so that we can know who is infected and provide referrals to the best care that people can have, or to what prevention interventions they need to continue, should be provided. So we need to have guidance on testing strategies and what algorithms and the algorithms to be used and who to be tested or prioritized for testing. Now, in terms of prevention of HTLV1 transmission, a lot of some work, we looked at mother-to-child transmission and especially related to breastfeeding cessation. We heard earlier that breastfeeding is one of the primary routes of transmission from mother to child. And from studies in 2008, for a 20-year evaluation of breastfeeding cessation in Japan, show the incidence of HTLV1 infection among formula-fed children was significantly lower than in breastfed children. But at the same time, we recognize the benefits of breastfeeding, especially in low resource settings where safe drinking water and adequate formula supply are not guaranteed. So in Japan, there was the use of the free store method was proposed as an alternative, allowing infants to consume breast milk, and it was said to be effectively eliminating the cells infected with HTLV1. But this is not practical for implementation if we have to scale up to elimination. So we need, and I heard in the presentation from Brazil this morning, support for safe formula feeding, given the benefits of given the benefits of breastfeeding. So there is that tension, but again, the analogy to my experience within HIV, this is what we did in the Caribbean in terms of the provision by governments of safe formula and formula for mothers who were HIV infected for the first 6 months. So this is one of the things we need to consider. The other is antenatal screening for HTLV1. And this is very limited. And I was happy to it is being done in Japan, but I was happy to hear of the progress being made in Brazil. And it is being done in some countries where for women from endemic countries or women who have partners from endemic countries. We have also HTLV1 screening of breast milk from milk banks, from, again, very targeted for specific endemic regions, women from specific endemic regions and their partners, and this is being done in the UK and Europe. We have limited again, and again, this seemed to be there, no particular, maybe limited in some areas to Brazil, where you do have some serological testing of children born to mothers who are HTLV positive, and where they are not breastfed, or if they are breastfed, the timing of the PCR test being 1 year and 3 years, as in Chile. So you have, what you are having is much variation. People are implementing interventions and there needs to be some guidance as to what are the benefits of some of these. Now, what is being implemented in many countries is the antibody screening of blood donors. Over 23 countries, but all the presenting countries today, and I would say, and Dr. Ruben mentioned it earlier, many of the countries in Latin America and the Caribbean, as well as Europe. This is the most frequent intervention that exists at this moment. Another intervention in terms of reducing transmission from blood is to effectively reduce leukocyte reduction, which effectively reduce the risk of HTLV1 infection, and it may be as effective as the screening, blood donor screening, but again, it's limited to Europe. Well, this area, I think we had a significant discussion, especially towards the end, related to the reduction of sexual and HIV drug use, transmission of HTLV. There is no standalone program related to HTLV1 reduction prevention, but it's in some instances integrated with other interventions to reduce STIs. And again, it was pleasing to hear the work that's being done in Brazil and the advancement there. And I see that it is the possibility for other countries, especially because for us in the Americas, to work together towards this particular goal. I have come to the summary slide, but I want one of the things I don't want to forget is that the question, there was a question about targets or goal, and having worked on the reduction of mother-to-child transmission of HIV in the Caribbean, I remember we had a consultation that included many persons who looked at what are the targets? How do we set our targets? What are the milestones? What are the effective interventions? And this is something that will be needed if we are to move forward with the elimination of HTLV1. So in my summary, we need to close the gaps in the knowledge of epidemiology, the public health impact, the disease progression and consequences. And this calls for investments in surveillance and pathogenesis studies. We need to know more about the condition and all the various conditions. Many HTLV1 prevention interventions are occurring in different settings. And this we heard this morning. I've tried to summarize a few of them. but guidance is needed on effective policies and strategies and services for HTLV-1 prevention towards the goal of elimination that can be adopted, and I would say in low resource settings. Otherwise, we're not, similar to HIV, it's not going to move forward unless it recognizes the need to be adopted in, that it can be adopted in low resource settings. We need to integrate and piggyback interventions into existing elimination strategies. And again, Ruben mentioned this in his presentation, and PAHO WHO has this integrated sustainable framework for the elimination of communicable diseases in the Americas. That includes a number, that includes neglected infectious diseases as well. And therefore, this is a good platform in which HTLV-1 can be integrated. We need to promote and address HTLV-1 in the WHO guidance on STI prevention, testing, and treatment and care, and a better understanding of HTLV-1 associated conditions as adult T-cell leukemia and tropical spastic paraparesis integrated into existing health programs addressing cancer and neurological diseases. Effective treatments and as well as vaccines, both preventative and therapeutic, requires an investment in HTLV-1 research. And that has not existed to my knowledge for a very long time. And this renewal is needed to enable this better understanding of HTLV-1. And my last point here really comes from the plea and the passionate plea of the patient advocates who have participated, or representative who have participated. And again, learning from what happened with HIV, greater advocacy by all, but to include patients, and as well as removing stigma and discrimination. And I hope this has been useful, but I think there is the need, the next step, which really needs where the picture, what's the plan for the elimination? And it must be done collective, not by individual countries, not, maybe we can start here in the Americas too, since we have that platform, the PAHO platform for the elimination of communicable diseases. But I thank you so much, and I'll end at this point.
Thank you, Noreen, for summarizing so neatly the approaches, the areas that we need to be tackling, and making the point that we need to be moving together. And it's on that note that I will close the session. We have a 15-minute break. We reconvene at 11 o'clock. That's Buenos Aires, Rio time. And I just want to thank everybody for taking part. I want to thank people in the chat for all the supported comments that we're going through. It's really great to see, for the questions that have been not only asked but also answered by people in the Q&A, and of course my thanks to the people who did all the hard work in setting this up and keeping it running, and again to the interpreters. Thank you very much. Ricardo, are you going to say anything, or do we just reconvene in 15 minutes?
Just thank everybody, and we reconvene in 10 minutes. Thank you very much.
Thank you all.
coloca a seguinte.
Good morning to everybody who is still with us for the session, for the second session. And we will have now an exciting time for question and answers with 4 renowned researchers and investigators. First of them will be Professor Edward Murphy, who is an emeritus professor of the Laboratory of Medicine and Epidemiology at the University of California, San Francisco. He is a senior investigator also at Vitalanten Research Institute, and he's focused on the epidemiology and pathophysiology of transfusion-transmitted viruses, including HTLV and 1 and 2, HIV, and hepatitis B and C viruses. The second person to join us will be Professor Peter Figueroa. Professor Peter is a professor of public health, epidemiology, and HIV/AIDS at the University of the West Indies, Mona, Jamaica. He is chair of PAHO's Technical Advisory Group on Immunization and a member of the World Health Organization Strategic Advisory Group of Experts on Immunization. He is also a member of the WHO Working Group on COVID-19 vaccines and a member of the UNAIDS Scientific Expert Panel. He was awarded in 2019 a World Health Organization Award for Leadership in Global Health. Professor Patricia Garcia is a professor and former dean of the School of Public Health at the Cayetano Heredia University in Lima, Peru, and she was a former Minister of Health in Peru. She is recognized leader in global health and a member of the Commission for the Education of Health Professionals of the New Century, and chair of PAHO the Strategic and Technical Advisory Group on Disease Elimination. She is affiliated professor of the Department of Global Health at University of Washington and the School of Public Health at Tulane University. She is actively involved in research and training on sexually transmitted infections and HIV, and a member of the United States National Academy of Medicine, and she was the first Peruvian to hold such a distinct. And Professor Mirna Biglioni from Argentina, who is a medical doctor also and a specialist in allergy and immunology, and coordinator of the National Reference Center of HTLV Group, the CONICET Institute in Buenos Aires. We would like to welcome all of you and thank you for the time to participate in the present webinar to celebrate the HTLV World Day 2021. And it's a great honor to host you during this important discussion table. It is more than relevant to mention that we will discuss 4 different geographical, politics, social, and cultural situations. And sometimes we will find difficult to conciliate with all that will be exposed. The main objective is to think on how we will be able to take a step ahead and when dealing with the public health policies in the different scenarios in the Americas. We just believe we have to go ahead on behalf of the persons living with HTLV, whom we are celebrating today, and hope to generate brilliant ideas and actions. Each member will present the initial words in approximately 3 minutes, and then the specific questions will be posed to 2 members at a time. The answers will be in 5 minutes maximum time, and in case any other member wants to complement he or she answer, we'll have to the word for an additional 2 minutes. Unfortunately, we have limitations of time, and because we have several questions, interesting questions, and we have just a few time of 1 hour. Thank you very much again for everyone, and I'll ask for Ed Murphy to start his talk, please.
Great, thanks very much, Ricardo. I really appreciate your introduction and also the opportunity to speak to this really large group who's interested and concerned about HTLV infection. I think for someone who's worked for most of my career on HTLV, I'm very happy to be here, and I hope that I can contribute something in terms of background and information on the epidemiology. I'd like to, I guess, preface my remarks by saying that, again, I think perhaps the United States representative in terms of public health policy, et cetera, or myself speaking about those issues perhaps should go last, since I'm afraid that there's relatively little for me to report in terms of national policy for HTLV in the United States. And many of the other countries represented here have done much more in that area. As you know, it's now been, let's see, we're approaching 40 years since the discovery of HTLV. I think it's just about 40 years. During that time, there's been a lot known about the virus in terms of global epidemiology, transmission, disease outcomes, etc. And much has been done in some countries in terms of public health control of the virus. I'll have to say that in the United States, there's been relatively little done on a national basis. I was part of a CDC panel and panel of experts which put together a set of recommendations to prevent the transmission of HTLV which was published in 1993. I just looked at that document recently. Unhappily, there's been no update of that document since 1993. And perhaps one outcome of this meeting would be a recommendation that should occur. Let's see what else. That said, there is regulation in this country as in others about the to prevent transmission of HTLV in the blood bank setting. And I think that is happening, and screening of all blood products is mandated, and that's an important step. There is not any incorporation of HTLV as a sexually transmitted disease, as far as I'm concerned. In fact, there's really little knowledge among STD practitioners of HTLV, and there was also interdiction of for donated organs. There was a recommendation to screen those for HTLV, but that has been reversed in the past 5 years because of concerns about the false positive tests and therefore loss of organs. In fact, at this point, solid organs are not screened for HTLV. I think I'll stop talking there because there's really not that much more to say. That said, I think that the data does show that the prevalence and incidence of HTLV is declining in the United States, as best we can tell from large studies, mainly in the blood donor setting. But we don't know for sure if there are particular high transmission groups where that may not be true. So with that, Ricardo, I'll stop talking and pass the word on to someone else.
Thank you very much. And I would call now Professor Peter Figueroa for his initial words in 3 minutes. Thank you very much.
Thank you, Ricardo. I welcome this conference and this thrust to translate research into policy and programs. Over 60 years ago, HAM-TSP was described clinically in Jamaica as Jamaican neuropathy. And we've done significant research. Ed himself was involved also in research in Jamaica with HTLV1. But unfortunately, this is not translated into meaningful policy and program. We do screen blood donors. That is 1+, but we do not have routine testing of antenatal clinic attenders or STI attenders. There's no surveillance. A clinical diagnosis is made. Usually persons with HTLV1, they're diagnosed on clinical basis. And up to recently, there was ongoing research on adult T-cell lymphoma, leukemia. Resources are a problem, and the fact that we have many challenges of diseases that are far more prevalent, and therefore the focus on HTLV1 is lost. I have 5 recommendations to suggest to this group in terms of policy. We've got to get areas where HTLV1 is prevalent. We must have blood donor screening. That's 1. 2, I really think we must have screening of all pregnant women, and they should be counseled either to limit breastfeeding to under 6 months, maybe 4 to 6 months, or otherwise use milk formula. I'm a breastfeeding advocate, so I prefer that they limit it to 4 to 6 months, and then they can also freeze, thaw breast milk. With respect to sexual transmission, I think we should consciously try and integrate more explicitly with the HIV STI control. The work that we've done in HIV control, promoting of condom use, treatment of sexually transmitted infections, clearly has an impact on helping to reduce HTLV1 transmission. But people need to be conscious of this, because despite all the research done in Jamaica and the Caribbean, most health providers, I regret to say, know very little about HTLV1. We should also test persons at high risk of sexual transmission, sex workers, MSM, and persons with repeat STIs, and potentially persons who are known to have multiple partners or who have sex with a sex worker. And finally, the fifth recommendation is that we must notify and counsel sex partners of persons living with HTLV1. Now, we do need to think of the economic implications. Our countries in the Caribbean have limited resources. Therefore, some seed funding to get some of this going, to get the involvement of the governments, to buy their involvement and get them started would help significantly. And we do the economic studies to show cost effectiveness and cost benefit. Thank you for your patience.
Thank you very much. I would like to call Professor Patricia Garcia for her initial words, please.
Thank you so much for having me here. It is a pleasure, and I want to congratulate our Brazilian colleagues for organizing this, and Pajo also. So I just want to start telling you that for this virus that was discovered in the 80s, even before the HIV, we should be ashamed, okay, for what little has been done. And when I ask myself, I mean, it was Fabiola who was asking why and why. Well, there is one why that I want to bring it, okay? Would it be maybe because it mostly is affecting women who are carrying the burden of HTLV infection and its associated diseases? Because we know that there is a high risk also of HAM in those women, and women who may carry also this worry of infecting their kids, and the anxiety of all the family that gets infected, etc. And just remembering something that Angelica Espinosa, Dr. Angelica Espinosa wrote in her article also, it probably is also because this neglected virus is affecting all the neglected populations, and low income, low educational level, indigenous community, women that several times end up having condomless sex or are affected because of domestic violence, and indigenous populations. So we should be ashamed because we're still with this disease. We are supporting all these inequities. And that means that we need to do something as a global community. So I come from Peru. In my own country, we have been, and I have to say that Dr. Eduardo Gotuso, who is here, has been like the pioneer, promoting the research in HTLV. And there is a group of people, and that's why we know that it's very prevalent. We know what is going on in different places. And actually, that also, his work and the work of other researchers, pushed the government to have certain policies related with blood donation and screening. However, very incomplete, because although we are preventing transmission between blood donors, so through blood into people, one thing that is not happening is communicating whoever is positive, that is positive, in order to be able to block the community transmission and find who else is infected. And that has been, again, because of an issue that has to do with financing. So the confirmatory tests are not available easily, okay? And that means that the most that you can do, I mean, it has happened even with me donating, okay? They tell you to, if you want to have your results, you have to pay for the tests, okay? Because they are not able to give you the tests. So it is really complicated. And in Peru, there has been a task force to work on policies regarding HTLV. And although the document has been ready for almost 2 years, almost 3 years now, it has not been approved. Unfortunately, it's very hard to shift the commonly held belief that since there is no cure, then it's better to do nothing, or that nothing should be done. So my 2 recommendations in general, because I think we need also a push from the global level, are: 1, I think it's great that Pajo is here, but it will be nice to advocate for the visibility of HTLV instead of lumping it within STIs, the same way we have now a program that is HIV, hepatitis, and STIs. I would say including HTLV. So it should not be it should be visible. That's 1. And the second, I completely agree with Dr. Peter Figueroa that we need financing. So we need to push for the same way that we have the Global Fund for tuberculosis, malaria, and HIV. We should discuss about the need of having a global fund that will help countries to work on the elimination of HTLV with all the recommendations that Peter has made and that we all know that will help.
Thank you very much, Professor Patricia. Now I would like to call Professor Mirna Biglioni for her initial words, please.
Buenos días a todos. Bueno, estoy muy agradecida de poder participar de este foro y es un gusto ver caras que ya nos venimos conociendo. Voy a hacer una pequeña presentación. ¿Se ve ahí?
Not yet.
¿Se está viendo la presentación?
Not yet. You...
Now?
Pero ponlo en modo presentación, sí.
Muchas gracias. Bueno, claramente Argentina está ubicada en el sur del continente, ¿no? De América, de Sudamérica, y ya ha sido reportado desde hace años 2 áreas endémicas, una para el HTLV1 y otra que es en el norte y centro, la región chaqueña, que linda con Paraguay, donde también hay una región para HTLV2. Si hacemos la descripción, vemos que esta publicación a nivel internacional es del año 2005, hay pocos datos posteriores, pero ahí vemos que claramente los donantes de sangre tienen alta prevalencia o una baja endemia, pero son prevalentes para HTLV1 y 2 respectivamente, pero si nos vamos a las poblaciones de originario, esta prevalencia aumenta un 3% en los Aymara y un 15% para Wichis y Tobas. Sin embargo, las patologías, tanto la leucemia como la paraparesia o los linfomas, son diagnosticados a lo largo de todo el país, en el resto de las provincias donde no son áreas endémicas. En este trabajo, que también es de hace unos años de nuestro grupo, elegí 3 trabajos como representante de lo que quería comentar. Vemos que en las trabajadoras sexuales, la prevalencia es baja en ciudades donde no pertenecen a un área endémica, pero si nos vamos a Salta, que es la ciudad del noroeste junto con Jujuy, vemos que esta prevalencia en trabajadores sexuales para HTLV1 era de alrededor del 5%. Hay pocos trabajos en trabajadores sexuales y otro tipo de poblaciones vulnerables. Como dijo la doctora antes, personas que tal vez no pueden usar un condón por problemas de su vida y su necesidad y su trabajo. Ahora, ¿qué sucede cuando nos vamos al resto del país, en áreas no endémicas? Este es un pequeño estudio que realizamos porque el N no era muy significativo, muy grande en estas distintas provincias, pero mismo ahí vemos que en mujeres embarazadas, tanto el HTLV1 como el HTLV2 están presentes. Yo marqué Ushuaia porque todos conocen que es el sur del país, junto al estrecho, a la Antártida, o sea que hasta en la zona más sur del país podemos encontrar una mujer embarazada con un HTLV1, y si vemos a veces los antecedentes de riesgo son o haber nacido en un área endémica de nuestro país como Jujuy, Salta, o de países como Perú, Bolivia, o haber tenido un compañero sexual positivo. Ahora bien, nosotros sí tenemos el testeo obligatorio en donantes de sangre, donantes de órganos, desde el 2005. Si bien ya desde 1997 había sido recomendado este testeo, no fue hasta el 2005 que devino obligatorio. De todas formas, no es obligatorio la confirmación del virus, ni el aconsejamiento. De hecho, para que haya aconsejamiento, los profesionales deberían estar capacitados, y para que estén capacitados debería haber un programa de vigilancia con difusión sobre el tema y capacitación. Tampoco es obligatorio testear o hacer un screening a las mujeres que donan leche humana, salvo de los 6 en un solo banco de leche humana del país. Y el HTLV, obviamente, como venimos diciendo, no está incluido en ningún programa de salud, de VIH, de ITS, de mujeres, de mujeres embarazadas. O sea que hubiera sido muy bueno que en este foro estén presentes autoridades de los ministerios de algún programa, porque ¿cómo pueden tomar medidas si no saben las medidas que tienen que tomar o lo que está sucediendo en un país donde un virus sigue siendo oculto o desatendido porque falta información? Tampoco existen guías ni recomendaciones desde autoridades oficiales. Y por supuesto, la prevalencia o la incidencia, mejor dicho, en donantes de sangre desde la ley ha descendido, esas unidades se descartan, no es un riesgo de recibir un HTLV desde un donante de sangre o de órgano, pero la transmisión madre a hijo, la transmisión sexual, sigue sin una respuesta, o sea que seguirá subiendo. Mi pregunta es, ¿cuántas personas pueden estar realmente falleciendo por leucemia sin un diagnóstico en áreas como una leucemia que la muerte viene en 1 año, en 6 meses, como se ha dicho, en regiones como el norte o Jujuy, o en regiones no endémicas, como fue el caso de los familiares de Emma, si no hay difusión y si no hay capacitación? En nuestro instituto nosotros ofrecemos el diagnóstico de manera gratuita desde hace muchos años, a muchos bancos de sangre del país, a hospitales. Hemos dejado de hacer el Western Blot por una cuestión de costo, de un monopolio, además de que daba casos indeterminados que después igual teníamos que confirmar por PCR, que es lo que hacemos una nested PCR para HTLV1 y para HTLV2. No recibimos para esto apoyo de ningún ministerio, simplemente lo hacemos desde nuestro grupo de investigación, y también, como yo soy médica, hacemos el aconsejamiento y el seguimiento. Desde la pandemia de COVID que nos dedicamos a ello, dejamos de hacer la carga proviral a los pacientes asintomáticos, pero lo retomaremos prontamente. También tenemos una página web que hicimos gracias a la colaboración con Fabiola y con la Fundación Aware, en español, donde recibimos a veces preguntas vía el mail, tenemos el Twitter, hacemos difusión, Emma colabora permanentemente, y nuestro grupo de investigación ha publicado algunos aportes y consideraciones al modo de guía o recomendaciones ya en distintos años, que una de ellas es la que está basada en las que Edward Murphy ha comentado. Este es un caso particular, para terminar, de un chico, un joven, Lautaro, con una leucemia crónica por HTLV, que es muy rara, que se lo medicó correctamente gracias a un ateneo con nosotros y con otros especialistas, con AZT interferón, que recrudeció durante la pandemia en 2019 por la falta de acceso a la medicación, que sabemos que igual es difícil porque el interferón ya no se usa para hepatitis, hay otros medicamentos, y la ZT prácticamente para VIH tampoco, entonces es un problema. Actualmente Lautaro está bien, recibió la primera vez que una trasplante de médula ósea en nuestro
Mirna,
país.
we have to stop, Mirna.
Sí, quería agradecer nuevamente, y creo que para comenzar, una de mis sugerencias es que antes de hablar del costo, del costo-beneficio de la inversión monetaria, no tenemos que dejar de olvidarnos que la salud es un derecho para todos, y quizás podríamos comenzar, al menos que no es tan costoso, pensar en un step, en lo que sea todo lo que es la información, la vigilancia, la difusión, y seguir adelante entonces por un camino que ya sabemos cuál es y que creo que en este momento ya no podemos volver atrás. Muchas gracias.
Gracias, Mirna. We would like to start the discussion, and I wanted to call the first question and direct it to Professor Peter Figueroa and Professor Patricia Garcia, please. There is a recent published letter asking for the eradication of HTLV, and the focus of the meeting is to establish public health policies towards the elimination of HTLV. Do you believe that this is a feasible and attainable aim? And we would like you to discuss whether it's feasible or not, and which goals should be reached: the associated diseases, the virus elimination, or mother-to-child elimination. Who would like to start? Peter or Patricia?
Yeah, I don't think we should get into an argument about whether we can eliminate or eradicate HTLV1, but we certainly can do better than we're doing to reduce the mortality and morbidity from this condition. And I think mother-to-child transmission is very important, because once we test pregnant women and counsel them with respect to breastfeeding, we can drastically reduce transmission of HTLV1 and later life adult T-cell lymphoma leukemia, which is quite a distressing disease, as one of our panelists earlier on described. So we can make a huge difference there. And we can also help to reduce transmission if we reach the persons who are tested positive through blood donation or antenatal clinic testing or testing of other high-risk groups, and counsel them and counsel their sexual partners. So for me, the thing to do is to put the emphasis on rolling out a meaningful program to reduce the transmission and reduce the mortality and morbidity that arises from this disease. Once we put that in place, we can then set meaningful targets in relation to elimination. Thank you.
Thank you so much, Peter. And actually, I completely agree with Peter. Being the chair of the stag elimination strategy from PAHO, we, together with all the group, we saw the opportunity of highlighting the fact that we knew enough and we know what is the burden of disease in several of our countries. And so we use that opportunity to make more visible HTLV. So that's why it's showing as part of this elimination strategy. But I also completely agree that if we have done it or we're working towards elimination for HIV and hepatitis, we should do the same for HTLV. But maybe instead of thinking of, what will be the indicators at the end, we should have indicators that go to the things that we know could work. We already have programs that are working on STIs, promoting condoms, but the fear is that now that we're introducing PrEP, for example, condoms could be forgotten, and that is going to cause all STDs to go up. And so there is the risk of more transmission of HTLV. So we need to talk about this. So the issue of awareness within the public and the providers is critical. We are doing a good job in general, I think, especially in Latin America, trying to eliminate congenital syphilis. And we are in Peru, for example, we have the dual HIV and syphilis test. And now we are adding a hepatitis rapid test. So piggybacking a test for HTLV, introducing that in antenatal care should be done, must be done. It's true that we still need a rapid test, but there are some countries, I think Japan, Korea, that are working on those. So how can we create a passage so we can have those rapid tests also that will be the tools that we need to make this feasible? So if you ask if it is feasible, I think it is, okay? We are doing already screening of blood donors, but as you heard also from Dr. Biglioni, we are doing it, but we're not completing it, counseling and doing the confirmatory tests that are needed. So we need to complete that too. I think the fact is that we have been ignoring HTLV. So now is the time to do it. It's feasible, and we need to make it more visible. We need also to confront governments. And again, we have learned from COVID that unless everybody is protected, nobody's going to be protected. It's the same thing here. Back to you.
Thank you very much. Is there any other comment, a short comment on 2 minutes no maximum? No. So, okay.
Sí, yo hago un comentario breve. Es la primera vez, gracias a este foro organizado por la OMS, que, por ejemplo, nosotros vimos un mail desde una de las autoridades del Ministerio de Salud. O sea, el marco de la OMS, este foro, es como un antes y un después para la importancia que puede venir de ahora en más para la visibilización del HTLV e inducir a la toma de decisiones.
Thank you very much, Mirna. The second question will be directed to Professor Mirna and Professor Murphy. And we are now talking about elimination of HTLV. But the present scenario is quite different among the countries in the American continent, as you already saw. What is the present epidemiological situation and spread of HTLV in your country? Are there sufficient and adequate information to quantify the problem in your country? Who is going to be the first? Mirna, go ahead.
Bueno, yo. Todo depende desde qué punto de vista. Hay información suficiente como para que estemos ahora participando de este foro internacional, porque hay grupos referentes de HTLV a nivel de ciencia. Actualmente también hay algunos médicos, acá hay un médico que está en el chat, Federico, bueno, que han llegado a participar de este foro, pero no hay información suficiente proveniente desde las autoridades, o sea, que son las que tienen que estar implicadas para la toma de decisiones, o sea, de los ministerios de salud, en este caso. Entonces, eso es un link que nos falta, ¿sí? Entre la Organización Mundial de la Salud, bien arriba, entre los referentes que estamos trabajando el país, tenemos que captar ahora a los que van a tomar las decisiones a nivel nacional.
Ed, would you like to?
Yeah, thanks, Ricardo. And I want to apologize to everybody. It's still night dark here in San Francisco. That's why it looks so black in my room here. It's early morning.
I appreciate you. You're all raking.
Right. Anyway, I think just to say, I think the one thing that we could all do for surveillance to know what the epidemiological situation is, and as you know, many of you know, I've been working in the blood bank setting for a number of years. That is an area where we can keep track of the virus. Admittedly, it's not ideal because it's not a high risk population. But if you test first-time blood donors, you do have a snapshot of prevalence in the general population, particularly among young people. But important to do confirmatory tests, as everyone knows, if at least on a portion of those to get accurate measurements. And if you also have access to repeat blood donors, and if you have enough of them, you can do studies of HTLV incidence. And those are basically the data that we have in the US on terms of, and what I referred to earlier, of declining prevalence and incidence of HTLV in the United States. We don't have a lot of detail on that, but at least we know that the virus seems to be going down. And I don't think, as I said, it's the result of any public health program, because there aren't any prevention programs, but it probably is a secondary phenomenon due mainly to a birth cohort effect, that the earlier populations with the higher HTLV levels have now aged out, and are the younger people thankfully seem to have less. Now, that's not always true, because in Japan they're showing that, again using blood donor data, that the prevalence is actually increasing in urban youth, in young people in Tokyo, and the same may be true. Recent data that I've seen from Brazil, where although the overall prevalence is stable, there may be some increase in young people. So I think that would be my suggestion, is to try to do some basic surveillance using blood donor testing, which seems to be common almost everywhere.
But my question is for everyone who wants to answer. But can we work without proper information? Is it possible to prepare prevention and control measures without information? Because if you go for blood screening, as you mentioned, if you make one here and the other 2 years later, can't we have any bias of sampling and other things that could influence the impression that the prevalence is going down or the incidence is going down? Can you comment on that?
If you allowed me, so definitely, if you try to do anything without information, it's like you're trying to walk blindly, okay? So that's why one of the things that is also quite important is to, as part of this system, is to create a registration system, notification system, okay? Which is one of the things that we need together. So part of the policy should be to have a compulsory notification, as we do for HIV, for example, and that will help not only to identify what is going on, but it will help as an indicator of the burden. It's quite important to advocate for financing and for the success of the program. In our countries, we have had in different countries information from different sources. In Peru, for example, there is a recent meta-analysis, and they found approximately 40 different articles which show prevalence in general population, 2.9%. Prevalence in women with childbearing age, 2.5%. Indigenous populations, the Shipibo, Conibo, which varies between 6 to 9%. In close relatives, about 30%. Female sex workers, 10%. People with parasitic diseases and tuberculosis, 30%. So we do have that, okay? But the problem is that several times researchers are on one side and policymakers are on the other. So definitely part of the policy will require to have this notification system, this registry, closer to the policymakers to assure that they know what they are doing, the effects of the policies, and also to advocate for the funding.
If anybody wants to comment in?
Well, I think our biggest problem that we face is that we've been doing studies for years, but we're not translating these studies into programs that make a difference to people who have HTLV1. So we test blood donors. We don't always, we just tell them they can't, if they're positive, they can't give blood. We do not necessarily counsel them or reach their sexual partners to counsel and test them. If we do something like testing pregnant women, then you're getting data. You are implementing a program, and at the same time, you have an idea, you're testing all of them if you're in an endemic area. So you have the data, you can track, and then you follow them up and make sure that you are doing something to make a difference. So I think we need to now institute simple programs, starting with antenatal testing, mother-to-child transmission prevention. And where there's capacity, you test STI clinic attenders as well, and other high-risk groups.
Ask.
Yeah,
I would like to ask.
I agree. Sorry, Ricardo.
Nick.
No, I just want to agree with what Peter's saying, that to basically use what we have. Admittedly, even the blood donor, I used blood donor data as an indication of data for prevalence, but it must be said that the counseling of those people is not necessarily well done. But I agree with Peter that really the mother-to-child transmission aspect is something that really ought to be done in all prevalence, high prevalence areas. Thanks.
Thank you. I have one question for Professor Figueroa.
Un comentario breve.
Oh, sorry.
Perdón, sí. Nosotros hemos hecho desde el punto de vista de la investigación y profesionales, hemos trabajado, hemos mostrado y hay publicaciones. La pregunta es ¿por qué las autoridades no toman la decisión de incluirlo? El HIV porque fue un boom, porque salieron los artistas, porque fallecieron, pero ¿por qué? Tomar una decisión desde la autoridad de un ministerio implica trabajo, organización, armar una red de diagnóstico, armar folletos de vigilancia, invertir. ¿Cuál es el motivo que tendrían para hacerlo si ninguna autoridad superior se los está pidiendo? Ahora, ¿realmente tenemos que seguir discutiendo después de más de 20 años que es un derecho que haya vigilancia y que haya capacitación de profesionales que puedan responder a las personas infectadas? ¿Se necesita realmente estudios de incidencia para ver esa prevalencia de Jujuy y Salta del 3%, si ahora subió al 5%? ¿Esa prevalencia no es suficiente para decir acá hay que tomar medidas para defender a las mujeres trabajadoras, a las madres embarazadas, a los chicos que van a tener una leucemia o una parálisis en silla de ruedas? ¿Qué es lo que más necesitamos para saber qué es lo correcto? ¿No?
Myrna, can you complement that with another question, which is, do you think that's the obstacle that you find in your country is the government policies or the government funding or the lack of will to do some minimum program, as Professor Figueroa says?
Well,
sí, a través de distintas autoridades que han pasado, por ejemplo, en el programa de SIDA de nuestro país, nosotros hemos comunicado la problemática. Entonces, o por una cuestión económica, o por una cuestión de falta de no ver la importancia de la realidad, o porque no se ve internacionalmente, que creo que ahora la OMS es la que está dando por primera vez este impulso, esas medidas no llegan a tomarse. Entonces, hay algo en esto que está faltando en la rueda, ¿no? Para que termine de cerrarse en toma de decisiones. Y si hablamos de inversión y uno dice, bueno, pero hay zonas endémicas, al menos toma de decisiones a nivel de algunas provincias de cada país o regiones, o una decisión, como yo dije antes, de por lo menos de un programa de vigilancia, de capacitación y difusión con los actores que ya están en los países, que de hecho están trabajando, y eso no es de alto costo, pero sería de alto beneficio.
Thank you very much, Myrna. Professor Figueroa, you would like to talk something?
Well, you know, there are many demands on the government and the Ministry of Health. And you know, there's a lot of push now to deal with non-communicable diseases, the leading causes of death. Obesity is increasing. We've been overwhelmed by COVID, and we have these periodic epidemics, whether dengue fever, Zika, CHIKV. And, you know, the governments and the technical people find it very difficult to handle more than one thing at a time. It's amazing that, you know, COVID is wiping out everything, and all the other programs, even routine childhood vaccination, is being undermined because we can't walk and chew gum or just do 2 things at once, much less 3 or 4 things. And then the demands on the budget are horrendous for the low and low middle income countries. It does help when WHO and PAHO are able to get a policy like a directing council, where you simply say, you know, we do have HTLV1, we can prevent this. Every country must introduce antenatal care testing, counsel about breastfeeding, and reach a sex partner. A simple first step like that, and you somehow find a little incentive, you monitor that, and you get the program going. Once you get that going, you can then expand more readily to STI repeat attendees or whichever other high-risk group you want to go to. But we need to get a start on doing something now, because all we've been able to do is test blood donors.
I would like to make a comment and a question also for you and to Professor Garcia, which is, how do we benefit from established health programs to implement public health policies towards HTLV? Can you comment and share with us your experience in the program of preventable diseases using vaccines, and Professor Patricia Garcia share her experiences as a former Minister of Health from Peru?
Well, my experience, to be honest, is quite frustrating, because we, for instance, have had a superb vaccine like human papillomavirus vaccine, and it took us over 10 years or more to get that introduced into the country. We have a superb vaccine like pneumococcal vaccine, which, if we get coverage in young children over 3 years, high coverage, it protects not only the young children, but it protects the elderly. And still, there are countries in the Caribbean that have not introduced that, including my country. So I don't want to turn into a negative mode. We have to keep trying to hammer that some of these clear, cost-effective preventive measures are being subordinated. They will get a CAT scan that after 3 years is non-functional. And if an MRI machine is coming out, they want that. They have centers of excellence. Anything that is curative gets the funding. But if it is preventive, it seems as if they're blind to it. And so it does help when WHO and PAHO can get a first step where it helps so the local voice gets the support of the international organization voice, because very often the ministers respond more to what they hear at PAHO Directing Council than what they hear from their local technical advisors. Over to you, Patricia.
Yeah, yeah. And I would like to add one more thing, okay? Let's learn from this story, from our history, okay? So when HIV started, unfortunately, okay, nobody wanted to talk about HIV, okay? But there were 2 important things. One was that big agencies like WHO, PAHO recognize it and start to give guidelines. But the other thing was the voice of the people that was very strong. And I think the fact that in this meeting also we are hearing about the patients talking is quite important. And I think we need to raise that voice. So that's 2 things. And I'm going to be a little bit more positive than Peter. Learning from HIV also, okay? Initially, for example, in Peru, nobody wanted to do any testing because everybody was so scared. Plus, there was this stigma. So starting with antenatal care it was like protecting the new angels and protecting the mothers that are innocent, right? So it was kind of like, okay, so we can do it. But what really helped to move on was the fact that we had a test that was rapid, that could be done at the point of care, okay? So that helped us rolling HIV testing. Then in Peru, we started an implementation study on a rapid test, and in Brazil too, okay? And there were like 7 countries around the world promoted by WHO doing the implementation of rapid syphilis tests, okay? And that allowed us to piggyback on the antenatal care, the HIV, and the syphilis test. And once the dual test came, and this was introduced in Peru in 2017, that has helped us a lot. So if you ask me where I would put my money and my effort, okay, and using whatever health policies we already have, I will go for the screening in antenatal care, okay? But we need also to push to have a point of care test that will help us to catalyze this process. And WHO and the Global Fund and will help us. I mean, I don't think it's gonna be that expensive. And we need a test also that could be accessible to all our countries, like the point of care tests that are like $1 and $1.50. And we are buying it through UNICEF, through PAHO revolving funds, etc. So that is something that needs to be done. And there are technically the capabilities, because I think in Japan and in Korea, there are researchers that are doing it. Okay, so we need those to be available and piggyback them in our programs. And I think with that, we will start moving the wheel that we need.
Thank you very much. Does anybody wants to complement that? Okay, so we can go further to the next question, which I would like to direct to Myrna and Ed. Are there specific characteristics which are blocking the access of persons who live with HTLV to the health system in your country? For instance, the screening of blood donors, which is not followed by confirmation, or access to secondary and tertiary preventive levels. Secondary like counseling services, and tertiary like physical rehabilitation, for instance. Who wants to start? Murphy, Myrna?
Sure.
Murphy.
I can talk just briefly, but it's yeah, I think we don't have, I mean, as I said, the only real place where HTLV is being diagnosed is in the blood banks, occasionally in other types of organ donation where people are screened, like, for example, for donation of for reproductive health clinics, etc. But and generally speaking, yeah, confirmatory testing is a little bit of a problem. Often we get information about that, but I think the bigger issue is a characteristic of the health system, and the fact that you know, as you all know, in the U.S. we have challenges regarding access to the healthcare system due to the way it's organized, and we've been making some progress thanks to Obama and now Biden in terms of increasing, you know, national health insurance for people, because as you know, the people who would have HTLV in the United States are those people of color, people of lower socioeconomic status. So, and those are exactly the same people who have trouble accessing general medical care, let alone care for HTLV. And then on top of that, there's the problem, which I think is general, of lack of knowledge among general healthcare providers about HTLV. We still face that even today. That really your average you know, provider, and there's not enough, I guess, general education about HTLV happening in medical schools. So with that, I'll pass it on to Myrna.
Myrna?
Sí, sí, claramente. Hay dos grandes problemas y no necesariamente hablamos de personas de bajo nivel social o por acceso a la salud. Los mejores bancos, los más grandes bancos de sangre de acá de la ciudad de Buenos Aires, que es la capital, a veces los médicos, por ejemplo, no saben cómo asesorar al donante que le dio reactivo. De hecho, nosotros recibimos algunos de donantes de algunos bancos de sangre de esta ciudad y de otras ciudades del país para hacer ese asesoramiento. Tampoco tienen, si lo derivan al paciente, si el donante recibe un resultado reactivo y el banco de sangre no tiene obligación de confirmarlo, tiene que ir a algún otro médico, infectólogo, hospital a preguntar. Y tal vez no saben a dónde, mismo los médicos o el profesional a dónde derivarlo para hacerse el test. Nosotros tenemos 2 o 3 laboratorios que hacen la confirmación a lo largo del país, pero no es algo no hay una red de diagnóstico organizada a través del Ministerio de Salud, de las autoridades, control de calidad de lo que se hace y la capacitación, tanto para el diagnóstico como para el asesoramiento de estos donantes. Y acá hablamos de los donantes, pero lo podemos trasladar luego a los pacientes. Por ejemplo, el conocimiento desde la hematología de cómo se trata una leucemia, recién ahora se están empezando a ver. Es escaso cuando existen guías de diagnóstico que por los referentes, tanto para TL como para la HAM-TCP. O sea que la falta de conocimiento es el primer obstáculo para una persona que va a recibir un informe de un banco de sangre o para un infectado acceder a todo lo que necesita para sus derechos a la salud.
Thank you, Mirna. I would have one more question for Professor Garcia and Figueroa, and I will ask for Professor Figueroa to leave for Patricia to answer first, because she has to leave in a minute and for another meeting. And the point is that on the day after of the publication from PAHO, presenting the decision to improve the knowledge about HTLV in the world and discuss public health policies, what would be the next steps in your point of view? If we were to start as today to include HTLV in a positive agenda, what should we do in your view?
Thank you so much. So the first thing is, I think WHO, which is at this point writing the directives and the big plan for prevention of HIV, hepatitis, and STIs. The first thing is to include HTLV, but from my point of view, they should make it very visible. And for that, even the guidelines should have the word HTLV there, which means instead of just lumping it inside STIs, should say STIs, including HTLV, which was one of the things that was done with HIV, okay, to really highlight their presence, okay? And I think there had to be those guidelines very clearly specifying the need for countries to do HTLV screening in antenatal care. I think that's critical. The other thing that I think it's needed is to at least address the 5 lacks as part of those guidelines. The lack of awareness in the population and health personnel about the disease, the lack of diagnostic capacities, so something has to be done, the lack of trained personnel on counseling, because people are fear what they are going to tell somebody. It's like, you have this virus and I have no idea what you can do. I mean, and that's what is happening. The lack of services to follow up patients, to offer therapeutic options that at least at this point should focus on the clinical diseases that are associated with infection, the same way we started with HIV, and that should improve the autonomy and the quality of life of patients. And the last one is we should address the lack of policies. And the lack of policies several times had to do with all the previous lacks, plus the fear of not knowing what to do. So the only ones that I think will help the world to address this should be WHO and PAHO with very clear guidelines. And I really want to thank you and thank the organizers and everybody, because, I mean, even having a day for HTLV to start raising the awareness of what this virus is and that there is something that we can do. It's not, I mean, we can prevent it. So why we don't start right now? So I think this is great. Congratulations. And I think that maybe this will be the tipping point. We just need to push it a little bit more because we also need funding for research, and research cannot stop. Thank you so much. And sorry, I have to leave.
Thank you very much, Patricia.
Yes, Ricardo, I think Patricia has said it well. So we have the program for the elimination of mother-to-child transmission for HIV, congenital syphilis, and hepatitis B. And we need, certainly for the Caribbean and for some of the South American countries, we need to add elimination of mother-to-child transmission of HTLV1. And that is the testing of the antenatal, the pregnant woman, and dealing with reduction of the time of breastfeeding. So I think we need to, she said it very well, but we need that explicit elimination goal for HTLV1 so it becomes visible, and countries have to address all 4 diseases, not just the 3. And that would get us started with the pregnant woman. Once we get that started, of course, we do need a better test, a rapid test. Then it's easier to add on the other groups. Over.
I have one question for you from one of our viewers, is Aide Nunes da Silva. And she's saying the following thing, is Professor Peter, you are defending the mother-to-child, not mother-to-child, but the breastfeeding and the contraindication for pregnant positive women for HTLV. Isn't it absolute? Even with the breastfeeding for up to 3 months, can we risk in this orientation?
Well, you know, that is the mother's choice. It is our responsibility to inform the mother and explain to her what is the risk and the benefit, both for breastfeeding and not breastfeeding. And together with her, help her to make a decision that best suits her. We have to be very careful of imposing our viewpoint. We've seen this in HIV, where you tell a mother, no, you must not breastfeed at all. So they say, yes, doctor, yes. But then because of peer pressure, and the peers of that mother don't see the mother breastfeeding, so they do breastfeed, and then they partially breastfeed. So the studies have shown, as far as I know, that if you limit breastfeeding to 4 to 6 months, under 6 months, the risk of transmission is much less than if you go beyond 6 months. So if you explain this to the mother, in my view, the mother could breastfeed and then introduce weaning foods and manage quite well. And in life, you have to be careful of trying to get the absolute perfection. None of us are perfect. And if we go for perfection, we often cause more problems. So this is a process of empowering people to make the decision that suits them best, and we support them.
How do you think?
¿Puedo agregar un comentario?
Sí, please, por favor.
No nos tenemos que olvidar que las personas que van a desarrollar la enfermedad son el 3 al 5% de los individuos infectados. Entonces ahí también con conocimiento los profesionales podrían aconsejar y saber que en una familia donde hubo antecedente de leucemia o parálisis van a tener mayor riesgo de desarrollar la enfermedad. Y ahí también entonces para una toma de decisión con respecto al amamantamiento. Lo importante no es decir qué hacer, sino decir qué puede suceder. Siempre hay que ser objetivo, obviamente, y ante las preguntas y las dudas vendrán las respuestas. Y para esa respuesta volvemos a lo mismo, y es que necesitamos estar capacitados para darlas.
Ed, would you like to talk something, to say something?
No, that's fine, Ricardo. No, yeah,
Okay.
thank you.
What do you think that we should do in order to promote people to get funds for research on HTLV? Because as a neglected disease, most countries just don't put any call for research programs on HTLV, and you always have to put it by a peripheral view of IST and things like that. And you have to convince the funding agencies also that they should start promoting the promotion of data on HTLV. How do you think you can work for that?
Yeah, I think we should brainstorm out some possibilities and think of some of the significant health research funders. But it was striking me that Carter Foundation, for instance, does support some of the neglected diseases. So we could look at different foundations, including Gates, those funders who fund neglected tropical diseases, Carter Foundation. We'd have to brainstorm some of those foundations, target them, and talk with them. But you know, we just have to advocate on behalf of what we are trying to do and explore where we can get the funding. Sometimes it comes in from sources that you least expect, but at least if we get the program going and start testing women, and then they become advocates, the pregnant women become advocates on behalf of the program, it helps. I think we need to take the first step and go from there.
Do you believe that?
I agree. Sorry, Ricardo. Just wanted to add that, yeah, this is a long-running question that we bring up at most of the HTLV conferences, and I think there's no, Peter is right. There are ways to creatively think about it, but I think the real best way is just to encourage young students who are interested in HTLV research to just come up with interesting research questions, to do the preliminary studies, which can be done at low cost. And then if they have data, they'll be able to get funding through the more traditional mechanisms. I think, it really is we just have to pass on, and that's unfortunately a fault in our country, in the US. There's not been a good generation of a new or passing on to a new generation of researchers, particularly in the epidemiology side of things. There are a number of basic science researchers, but that's the other concern, not just funding, but people, young researchers who will carry on this study. Thanks.
Mirna, do you want to say something?
Sí, a veces el problema también en nuestro país al menos es que a la epidemiología no se la considera ciencia, ¿no? Como que siempre es la ciencia básica lo importante. Nosotros tenemos muchas publicaciones epidemiológicas que no son consideradas al momento de uno ser evaluado a nivel de investigador, pero bueno, que sí sirven y son una herramienta útil para el campo de la salud pública y la toma de medidas. Entonces, que creo que lo que nosotros tenemos que acá, que vamos sobre esta toma de decisiones, encontrar fondos que sean para la aplicación a nivel de la salud pública. Y quizás yendo por el lado del cáncer puede ser algo importante.
Do you believe that with this involvement of PAHO in making this infection more knowledge to everyone, that will help to create initiatives that change this situation? Peter, Mirna, Murphy?
Claramente sí, y nosotros hemos tenido la respuesta con este foro. Por primera vez un mail, como yo dije antes, un correo que llegó desde una autoridad hacia otras autoridades y nos copiaron a nosotros. Por primera vez. ¿Sí? Si bien nosotros hemos comunicado antes, pero ahora, bueno, es la OMS, entonces es PAHO. Y eso le dio un peso y por eso creo que desde acá es un nuevo comienzo.
And I was very happy to see your interview in one newspaper or online or something like that. That was very good. Thank you very much for your initiative on that. Professor Figueroa, you want to say something?
No,
were we correct to involve PAHO and the WHO?
Of course.
Yeah. And I want to say also that the work that that Fabiola and Graham have done on the WHO side, which stimulated that that meeting in Tokyo in November of 2019, and then the subsequent documents coming out of WHO, that's definite progress. So I think that's really important work, and I think we owe that thanks to our colleagues on that.
Does anybody wants to say anything else to finish this discussion? Because I have to say the final words in regard to summarize all that we have talked about. Does anybody wants to say something? Just for the closing.
No, I think
closing remark.
Just thank everybody for the invitation, and unfortunately, I'm going to have to drop off in a few minutes too while you're talking, Ricardo. I have speaking of grants, I'm on a NIH grants committee, which starts in 12 minutes from now. So anyway, but thanks everybody, and great to see my colleagues, Peter, Myrna, as well. So thank you.
Yeah, Ricardo, I just want to say how much I appreciate this initiative. It's been an excellent meeting, excellent initiative, and it will be great to see this going forward in a programmatic and policy specific area. So great work. Let's keep at it.
Thank you very much.
Muchas gracias y por la excelente organización, además, y gracias a todos los pacientes y la audiencia. Creo que es un inicio excelente.
Thank you very much. I have to make some closing remarks in regards to what you just discussed. And what I have to say is that this is an initiative from the HTLV channel on the persons of Carolina Rosadas and Tatiana Yasson. And now I think I am an emeritus member of the channel, and now Leandro also Sereno became just another one, the member, an emeritus member of that as well. But when we thought about calling the support from PAHO and the World Health Organization, it was a long way. We had to pave this program to fit in all the directions that the PAHO and WHO wanted, and all the work that we had, I believe it was well done. All the time that we spent, it was great, because what we are seeing now is that their support is essential for whatever we need to promote in the future. And see, all of you have mentioned several things that are common to our thoughts as well, and the thoughts of everyone that presented or the presentations that came before you. We are stressing the screening of pregnant women. We are stressing the transmission, the sexually transmission of HTLV as one of the most important points. The risk of persons to get HTLV among the others sexually transmitted infections, the lack of notification, which was repeatedly mentioned by all of the panelists, the vulnerable population. It's funny because we have very few data on females female sexual workers. We have a lot of few data on other vulnerable persons, indigenous people, which we will have a discussion later on. But the absence of information, it calls our attention very heavily, because it seems that people is not bothering to get educated about HTLV on medicine faculties, biological faculties, pharmacies faculties, and every faculty in the health area. And that makes an enormous problem because of the personal preparation for treating, for counseling, and all the other needs that we have for HTLV, because it is one special need is to have people who can handle HTLV infected persons and HTLV diseased persons. But one thing that I missed a lot is the absence of mentioning HTLV2. One of my discussions sometime with people in Australia is that they have a terrible burden there with HTLV1. And we in Brazil, we have a terrible burden with HTLV2. It is different because we have a minimum amount of possible disease. But every day we have more and more and more papers stating that HTLV2 is able also to cause such and such and such diseases. And we have to make sure that at least this small group who works or thinks about HTLV do not leave HTLV2 aside. HTLV2 is also important. I wouldn't like to see that in under neglected disease or under neglected virus. HTLV is already neglected, but HTLV2 seems to be under neglected. And it's good that we change our thoughts about that. It's very interesting to state that no eradication or no elimination will be feasible. I in some part, I do agree with that, because as a virus that causes persistence, it stays with us for the rest of our lives. And I'm not quite sure how we will prevent the transmission of these viruses when we don't even know they are there. And so we would have to look for very carefully for that. But also the other important point is, which was mentioned by Angelica earlier on, which is notification of the infected and diseased people. If we do not say, if we do not look for who is, we do not know the numbers. If we do not know the numbers, we do not know what to do. on HTLV. So I hope that this meeting is, as you said, a point to separate before this meeting and after this meeting to take care of the persons who are living with HTLV. I thank you very much. The organization thanks a lot for all the participants and all the panelists who were with us in the morning, though our friends from Australia who were far ahead in time from us, but who kept there for as long as they could. And now we will do a little break and we will reconvene by 14 at 2 p.m. Okay, and I welcome everybody to be with us again at the session in the afternoon. And this session will concentrate a lot more in the Americas. Thank you very much for everyone. Thank you, Myrna. Thank you, Peter. Thank you, all the participants in the debate. And so, thank you very much.
Gracias.
Okay, thank you.
Bye.
Eu. Leandro. Então a gente volta às 2?
Vamos às 2.
Olá. Sim, a gente volta às 2. E acho que não precisa, quem quiser continuar não precisa desconectar, que a sala vai ficar aberta. E às 2 a gente volta com a apresentação do Dr. Gotuso.
Carolina está por aí, será? Carolina não me deu, a Carolina não me falou como que ela quer ser apresentada. Eu gaguejei muito, gente.
Não, foi tudo bem. Eu acho que, porque acho que vai estar continuando a transmissão. Não sei se o Juan Davi pode pausar só ou se vai tudo para o ar.
Está recording aqui, ó.
No, está em pausa, Leandro.
Ah, ok. Ok.
Tá bom, então?
Ah,
Nós vemos daqui a pouco, então.
Foi ótima a sua apresentação, Ricardo.
Obrigado, Tati. Se alguém falar com a Carolina, pede para ela me mandar como que ela quer ser apresentada, tá?
Perdão, desculpa. O pessoal tá ouvindo os bastidores agora aqui.
Hola, Juan Davi, hay un eco. No te escuchamos.
¿Me pueden escuchar?
Ahora sí, está mejor.
Leandro, sí, están pausadas las reuniones, pero tomen en consideración de que YouTube está corriendo.
Ó.
Ok.
A Meire está dizendo que está nos escutando.
Sim, ok.
A Edel também está aberta.
Ok.
Entrada de palestrante organizador. Daí você me escutou. Só seu
Sim.
É que a gente tem conectado em 2 lugares, mas na hora que eu for apresentar, eu vou conectar em um só. Então, até mais tarde, gente. Obrigada.
É que eu estou ouvindo também, né?
Voy a poner en mute.
¿En cuánto rato volvemos a comenzar?
Por favor, agradezco cualquier comunicación que sea por interno.